take those 1.5 points in your pocket. So now I'm gonna to invite Dr. Neeraj Jain to share more details for today's event. Dr. Neeraj Jain is president of MELAP, Medical Education and Learning Point. He is also the secretary of Association of Practicing Pathologists and member of the governing council of Association of Indian Laboratories. He is also on the scientific advisory board of TIDE. So this CME has been organized by MELAP and by MELAP, and from my side, I would like to call Dr. Neeraj Jain for his introductory speech. Welcome, sir.
Thanks a lot, Vidhi, for your kind words. And first of all, I welcome all of you in this TIDE 2021 being organized by Medical Education and Learning Point. This is a long academic bonanza consisting of 4 lectures from the expert of their field. And in this, you will listen to very knowledgeable and experienced speakers, and all of you will be benefited by their experience, by their knowledge, by their way of delivery, their knowledge. But the big question is, you may be wondering, why all this thing is required? All of us are qualified doctors. What is the need of all these CMEs for us? But I think all of you will agree with me, medicine is an ever-evolving field. New tests are being developed every day. What is the indication of a particular test? What is the best method to perform that test? What are the quality control measures we are following? What is the interpretation of a particular test? And how much time this test will take to be performed, and whether after that time it will remain meaningful or not. And these days, everybody is talking about point of care testing, how we can release result as early as possible, as close to patient as possible. We are talking about point of care testing also. So how we can incorporate these tests in the point of care testing. All these things are a big challenge for all of us. First thing is, we have to update ourselves with the new techniques. Then there is expectation of accuracy, expectation of as minimum turnaround time as possible by the clinician. And when we are developing new tests, how to develop quality control for that test, and how to standardize a particular test, how to develop harmonization in that test. All these things are big challenge for all of us. And then first we have to develop this knowledge, and then we have to impart this knowledge to our staff, our colleagues, to clinicians. So how we can carry out all these things in a meaningful way. And when we are carrying out all these things, then again a big question for regulators, administrators, clinicians, patients, what is the cost of a particular test? How we can keep this cost as minimum as possible. So these are the different expectations from different bodies, different persons, to answer all their queries and to update ourselves with the required knowledge. We have planned this TIDE 2021. So now I will request Vidhi to introduce our speakers, and before that I will welcome our all faculty and participants once again, Dr. Chavi and Dr. Banali. I can see both of them, and the rest of the faculty will join shortly. So now Vidhi, please.
Thank you, sir. It's my pleasure to be with a bunch of doctors, and everybody is very beautiful and very shining in their era. So thank you, Dr. Jain, for your inspirational words. Now moving ahead to the agenda of the day, we have 4 sessions within this CME. We will be covering the following topics. First will be secondary infection in COVID-19. Then we will go with the HbA1C unit number and method. Hepatitis, interpretation of hepatitis markers. Then we will go with updates of celiac diseases. So to call my first speaker of this day, of this CME, I'd like to call for this first CME session on secondary infection in COVID-19, and the expert deliberation will be undertaken by Dr. Hcv Gupta. So welcome, ma'am. Dr. Hcv Gupta is a consultant, Northern Railway Central Hospital, New Delhi. She has special interest in immunology, fungal and viral infections, infection in immunocompromised patients, and hospital infection control. She has more than 20 publications in national and international journals. She has contributed in antibiotic and antimicrobial resistance policy of All India Institute of Medical Science. She has also contributed in development of an AIMS antibiotic policy, MBBS, MD, DM applications, and available at Google Play. You can see it. She has also contributed in drafting the COVID guideline and policies at AIMS New Delhi. Now, stage is yours, Hcv ma'am. We are going to welcome Dr. Hcv Gupta. Ma'am, please.
Thank you, Ms. Vidhi, for a warm welcome. So, in this chilly weather, let's start with today's topic. So, currently now we are in the second year of the pandemic. The year is again going to end, and still we are struggling with this pandemic. And even when we think that the life will become normal after a few days, then you can see again there is a spurt of news that new COVID variant has again shaken up the world. This variant will trigger another wave, or this variant has now already entered in our country. So this variant is now already welcomed in our country. So with this variant, again, there can be a rise in the COVID cases. So my topic today is secondary infections in the COVID. For all last 2 years, and in the last first wave and second wave, we have seen so many of the COVID patients, and but we have never talked about any secondary infections and what kind of secondary infections that these patients can have while during the admission or after the admission. Yes, there was an outbreak of mucormycosis, and every webinar and every forum was discussing the mucormycosis. But apart from the mucormycosis, we can have plethora of the infections that are usually not discussed. So my talk will be mainly on the clinical scenarios. So let's start with the case. There is a 55-year-old male, hypertensive diabetes. He has history of severe COVID illness 1 month back and was managed with steroids and ventilatory support and was discharged almost after 20 days. Now, post-discharge, when he had already recovered from the COVID, 10 days after discharge, patient started having complaint of breathlessness and again landed up in the hospital in emergency department. On arrival, the patient look was toxic. Her BP and respiratory rate was normal, but there was a saturation drop of 95%. He was able to maintain on with the oxygen support. On examination, there was hyperresonance on right side of chest with bilateral crepitation. There was leukocytosis. Rest of the systemic and examination and biochemistry and other parameters were normal. So this is the chest X-ray which shows there were the bilateral pneumothorax with bilateral CP angle blunting, and the CT scan shows bilateral again pneumothorax with pleural effusion. There was lung collapse and patchy air opacities. So what could be this? It could be a post-COVID sequelae, but the patient has already recovered from the ARDS. So now for immediate management, bilateral ICD tubes were inserted since there was a leukocytosis, fever, broad spectrum antibiotics were given and other supportive measures were also started. On inserting bilateral ICD drain, there was a frank pus discharge, which this pus was then subjected to all investigations, microscopy, gram stain, Zn stain, fungal KOH mount, bacterial culture sensitivity, fungal culture, and gene expert. Now, the fungal and the tubercular workup was negative, but this pus sample grew Enterococcus faecium, which was sensitive to only linezolid and resistant to other antibiotics. So this VRE was isolated. Now, this VRE is a superbug which was diagnosed in this patient. So the patient was started on a linezolid and initially IV, then switched to oral linezolid. Gradually, patient started showing improvement, then was discharged. And finally, over the period of 8 weeks, the patient showed clinical and radiological improvement. So the final diagnosis was post-COVID necrotizing pneumonia with bilateral hydropneumothorax due to vancomycin-resistant enterococci. So post-COVID, there was a complication of necrotizing pneumonia and bilateral hydropneumothorax due to a superbug. So this kind of presentation the patient can have, and it cannot be ignored at any cost. So why there are increase in the bacterial or the secondary infections in post-COVID illness? First of all, as we have already seen during this period of 2 years that the COVID-19 illness causes immune dysfunction. There is a lymphopenia, excess pro-inflammatory molecules, there are cytokine storm, inhibition of the NK cells, T cells, and there are uncontrolled glycemic levels during the COVID illness. And we all must have seen that this COVID illness has uh, shifted patients who were pre-diabetic to the diabetic, and even the patients who were non-diabetic have now become diabetic after this COVID illness. There has been injudicious use of steroids and tocilizumab during this COVID illness. While during the admissions, severe COVID patients were admitted in ICU. There were multiple devices, mechanical ventilation, NIV, HFNO, central line, infusion sets. There are chances of aspiration of gastrointestinal contents, prolonged illness leading to bedridden status, leading to bed sores, skin and soft tissue infections. There has been injudicious use of broad spectrum antibiotics. So isolated wards were created, and there were fear among the healthcare workers limiting free medical and personal access. So there were lack of infection control practices and the antimicrobial stewardship practices. So there has been multitude of factors that is leading to increase in secondary infections with these superbugs are also noticed. Not historically, we all know that infection of any mammalian cells by the respiratory viral agents leads to disruption of the airway epithelium. Now the host cells become susceptible to increased bacterial attachment, leading to the biofilm formation. So these the post-viral respiratory agents leads to the secondary bacterial pneumonia, but most of these lesions, pathogenic agents remain localized to respiratory tract, but may disseminate to other site, leading to systemic infection. So the viral pandemics have always been complicated by secondary infection. In 1918, Spanish flu witnessed around 15 million deaths due to secondary bacterial infections. And even in H1N1 influenza pandemic, 55% of mortalities were attributed to secondary bacterial infections. Now with this current pandemic, this was a meta-analysis done by Langford et al. It included the initial period of the COVID-19 pandemic, when the pandemic started from December 19 to March 2020. Around 3,300 patients were enrolled from the 24 studies, and they noticed that the most common, the rate of co-infection was only 3.5%, while secondary infection was 14.3%. Now here, even in all studies, I have seen that the infection presenting within 48 hours of COVID positivity or admission to hospitals are considered as a co-infection, that is a simultaneous infection. While post 48 hours, then secondary infections are labeled. It may be a community-acquired infection or it may be a hospital-acquired infection, but most of these are the hospital-acquired. So the most common secondary infections are LRTI followed by the bloodstream infection, and but the incidence of these secondary infections were only 14%, but around 70% patients received antibiotics. In another study, the incidence of ventilator-associated pneumonia was around 50%, and bloodstream infection in COVID-19 patients were 25%. So this is the study conducted in ICU in Israel, where the secondary bacterial infections were compared in COVID patients were compared with the secondary bacterial infections in influenza patients. And it was noticed that there were higher rates of secondary bacterial infections in COVID-19 patients. 85% of infections were isolated from the blood cultures, while only 14% from the respiratory samples, while among influenza patients, this proportion of isolation of bacteria were equal between blood and respiratory cultures. Gram-positive infections are more common in COVID-19, and there has been emergence of enterococcus species in COVID-19 patients. So post-COVID MSSA pneumonia is common, but this VRE or the VRE has been recently diagnosed in this COVID era. It has been never diagnosed in H1N1 influenza pandemic. So this is the Indian study conducted in the 10 main tertiary care hospitals from north to south, east to west. and it included around 17,000 patients, and the rate of secondary bacterial or fungal infection was 3.6. It was only a 3.6%, but what is important to note is that among these 3.6%, the mortality was more than 50%, while the overall COVID mortality is 10.6. This is something alarming because overall mortality is less. So patient can survive COVID, but the patient cannot survive secondary infection if it is ignored. So this is important to diagnose and appropriately treat secondary infection. And the most common site of isolation of pathogens were mainly from the bloodstream, followed by respiratory and urine. Gram-negative pathogens predominated in respiratory samples, while the gram-positive predominance was seen in bloodstream infection. There were predominance of the MDR organism, and the emergence of Stenotrophomonas maltophilia has been seen in our Indian setting. And the Klebsiella pneumoniae was the most common, 29.3%. Now, initially, when this COVID pandemic entered the world, and there were no knowledge about this COVID pandemic, how to treat the patient, how patient will present, what is the significance of any biomarker, and what does the TLC count indicate. So, in a hush to save the patients, all the clinicians have landed up in using empirically broad spectrum antibiotics. So antimicrobial agents have been used empirically rather than against diagnosed infection, because there were the overlapping features of this bacterial and bacterial pneumonia and that's COVID pneumonia. There were overlapping radiology. So the clinicians were not able to make out the right treatment. So Zhu and colleague noted that secondary infections were seen only in 50% of the non-surviving patients, but the antibiotic use was around 100%. Similarly, study from the China showed that more than 70% received antimicrobial therapy, while only the rate of secondary bacterial infections were less than 10%. Similarly, in studies shown here, this rate of secondary infection was only 14%, but the antibiotics received were 70%. So this overuse and injudicious use of antibiotics has led us into another pandemic of AMR, where it will be difficult to treat superbugs in the coming near future. So this is a study from the India UCMS, where there has been noticed that there is a shift of around 40 antimicrobial resistance pattern. Up to 40% increase in AMR was noticed among the isolate during COVID-19 period as compared to pre-COVID-19. They compared the bacterial isolates and their antibiotic sensitivity isolated during COVID-19 period and retrospectively with pre-COVID-19 use. So the overuse of antibiotics gave abundant opportunity for bacterial pathogens to gradually develop mechanism of AMR and to acquire resistance. Even in Indian study, 47% patients were infected with multi-drug resistant organism. So this COVID-19 has led us into another pandemic of the AMR, which will be very difficult. This pandemic will be over somehow within maybe possible in next year, but this AMR pandemic is difficult to control unless and until we start using antibiotics judiciously. So there is a projection that the COVID-19 will lead to 1 lakh mortalities, and while the AMR will lead to 7 lakh mortalities in per yearly, and by 2050 it will reach up to the 100 lakhs. So this is an alarming situation. Now there has been we have seen cases of post-COVID TB patients also. So CD4 plus T cells plays an essential role in defense against MTB. But the COVID-19 patient, there has been significant depletion in the CD4 cell counts. Even the surviving T cells showed functional exhaustion. They were not able to act T lymphocytes will take months to a year for full recovery, as it has been evident in the SARS-CoV-1 infection, and a similar hypothesis is being used for the COVID-19 also. T cell depletion and dysfunction will promote the development of active TB in patients with latent TB infections. Apart from that, there has been use of steroid, tocilizumab, lung inflammation, post-COVID lung sequelae, and new onset diabetes in COVID-19 patients. So India is is an endemic country for TB. Vast majority of patient has latent infections. So COVID-19 can increase the incidence of TB in our country. That is why Ministry of Health and Family Welfare has recommended bidirectional screening. That is, every COVID-19 patient should be screened for active TB. Similarly, any active TB patient should be screened for COVID-19. So there is a graphical representation which shows that potential impact of COVID-19 on TB care cascade. Because of lockdown and isolation, fear of people in moving out, it will ultimately is going to affect the TB care. There will be a lot of dropouts from the TB program. So all these will lead to increase in the incidence of TB, and multi-drug resistant TB is also possible in this coming scenario. And we have to carefully watch over the next few years to assess the what this COVID-19 impact has been there on TB and the secondary infections. Now coming to second case, a 45-year-old female diabetic dyslipidemia hypertensive admitted in COVID isolation ward. Initial saturation was 70%, but it improved to 95% on high flow oxygen. COVID RT-PCR became negative after 12 days. She was discharged with home-based oxygen therapy, 2 liters per minute, and this oxygen support was gradually weaned off, that the patient was able to uh, remain without oxygen. But around after 30 days of discharge, she again started feeling breathlessness on exertion. There was complaint of weight loss and fever on and off. So here the X-ray shows some infiltrate. So chest CT was ordered, which shows cavitatory pulmonary parenchymal lesion in left lower lung, similar lesions in the bilateral lower lobes, and there was associated ground glassing, central lobular nodules, and traction bronchiectasis. So all workup was again sent. There was GD of tubercle or a fungal. Patient was unable to expectorate sputum. Bronchoscopy was done, and ball was subjected to microscopy, gram stain, Zn stain, fungal KOH mount, bacterial culture sensitivity, fungal culture, gene expert. Here now the KOH mount shows septate hyphae, and the serum galactomannan was, which is a marker for the invasive aspergillosis, showed 1.25, which is high value. So the diagnosis was post-COVID pulmonary aspergillosis. Now, what are the risk factors for the post-COVID fungal infection? Now, post-COVID fungal infections can be COVID-associated pulmonary aspergillosis, COVID-associated mucormycosis, or COVID-associated candidiasis. Again, because of the immune perturbations, there is a critical illness leading to ICU admission, multiple devices, mechanical ventilation, catheters, injudicious use of broad-spectrum antibiotics, total parenteral nutrition. There is a hyperinflammatory response in COVID. Steroids and tocilizumab has been used, but these drugs has been used rampant and injudiciously. That has been paving way for another infections. In Indian ICUs, there is a high fungal spore burden of around more than 80 cubic feet per cubic mm. So all these factors promote COVID fungal infections. COVID-19 and diabetes are collusion of two diseases. There is a hyperglycemic surge in COVID, leading to pre-diabetics, diabetics, obese, trigger new onset diabetes. Apart from that, there is high insulin requirement, ketoacidosis. Glycemic control is difficult to achieve because clinicians are not comfortable with insulin infusion. So adding fire to the fuel is the use of steroids. So there is again increase in the glycemic level. Now, COVID-associated pulmonary aspergillosis, the concept has been derived from the influenza-associated invasive aspergillosis. There was sharp increase in the influenza-associated aspergillosis after 2009 pandemic. The cause was not known. Probably there is a evolution of more virulent influenza strains, pandemic H1N1 strain causing more severe pneumonia, and improved diagnostics. This was a study conducted over a retrospective study conducted on H1N1 patients in 7 ICUs, and 432 patients of influenza admitted over a period of 7 years. Invasive aspergillosis was detected in 19% cases, median days after 3 days of ICU admission, and this was independent risk factor for aspergillosis. Now, why influenza predisposes to aspergillosis? Because there is a local damage to tracheobronchial mucosa, disruption of normal ciliary clearance, allowing colonizing fungi to cause invasive disease, impair local phagocytosis, immune dysfunction, lymphopenia, and exposure to the fungal spores of aspergillus at this critical time of reduced mucosal and systemic immune defenses, leading to invasive disease. Now, similar hypothesis has been created for the COVID-19 patients that how invasive pulmonary aspergillosis can occur in such patient, but there is a difference that influenza associated invasive aspergillosis, the median onset of time duration has been noticed around 3 days, maximum up to 7 days, while in COVID we have seen that it can occur after a month. So there is a delayed presentation of COVID associated pulmonary aspergillosis. There has been multiple case reports and series. Earlier study from China showed low rates of 3 to 25%. European countries had shown the rate of 20 to 35%. Median onset is 6 days, but it can go up to 30 days, and mortality is reported between 44 to 60%. Now, this is a study conducted in AIMS. 10 patients were enrolled. Again, the median duration of COVID positivity to a diagnosis of invasive aspergillosis was around 30 days. And the diagnostic modalities used were serum aspergillus IgG, galactomannan, isolation of aspergillus from the fungal culture, or aspergillus PCR in BAL. Now, we all know that in April, May, we saw worst of the COVID-19 pandemic. There was shortage of all medical infrastructure, beds, and there were many mortalities. Apart from that, what we noticed, there was a tsunami of mucormycosis among the COVID-19 patients. So, now this is a global epidemiology of the mucormycosis as is from the studies from India. Which shows that there is an annual incidence of around 24.5% in one study, 18%, 16% in another study, and the most common risk factor being diabetes. But why there was increase in the prevalence of mucormycosis during COVID-19 illness? Again, the common risk factors of COVID-related 19-related immune dysfunction, critical illness, hyperglycemia, hyperinflammatory response. Apart from that, there is an alteration in the iron metabolism, down regulation of iron export, hyperferritinemia leading to excess intracellular iron, reactive oxygen species, cell damage, and free iron in the circulation. So iron overload in acidemic state is a key factor. Apart from that, there was an endotheliitis which promotes mucor invasion. So the first wave, there were only few case reports and case series. Largest case series during first wave was 18 cases reported from the Bangalore of the rhinocerebral mucormycosis. Largest multicentric study conducted in 16 centers from September to December last year during the first wave. This was a retrospective analysis. But in second wave, there was an exponential increase in the mucormycosis. There was outbreak, even it became a notifiable disease. And as if now on 20th July, there was 45,000 cases of mucormycosis reported in our country. Now, again, sudden surge in mucor cases in second wave, probably because of more severe illness, more indiscriminate use of steroid even in home isolation. So this was the study conducted during first wave, that is a mucocovid network study in 16 ICUs. 287 mucormycosis patients were enrolled, and there was a among these 287 mucormycosis patients, 187 patients had COVID-associated mucormycosis. So COVID-associated mucormycosis prevalence was 0.27 among hospitalized patients. So as compared to the previous study, there was increase in 2.1-fold rise in the mucormycosis. And COVID-19 related hypoxemia, improper glucocorticoid use were independently associated with this disease, and the case fatality was 45%. So as we all know that the mucormycosis was made a notifiable disease by this by ministry. So this is a latest study where they have compared epidemiology and pathophysiology of the COVID-19 associated mucormycosis in India versus rest of the world. And what they noticed, 275 cases were enrolled. Out of this, 233 from India, 42 from the rest of the world. Again, diabetes was the most common underlying factor. The mortality reported from India was less as compared to mortality reported across the globe. There was only 36.5% mortality from the India, while the globally the mortality was 60%. And on multivariate analysis, it was found that pulmonary or disseminated mucormycosis cases and admission to intensive care units were associated with increased mortality. Even in my experience, what patients we saw, that there was a very indolent presentation and even subacute presentation, that mortality rates were not very high, which we normally seen in the mucormycosis. Now coming to another case, There's a 58-year-old man, again hypertensive, diabetes, history of the interstitial lung disease, admitted to the COVID ward due to COVID RT-PCR positive, initially on the 6-liter oxygen support with high temperature of 101, managed conservatively. However, within next 3-4 days, there was increasing oxygen requirement. Further worsening, patient landed up using high flow nasal cannula, high grade fever. Day 6, TLC was rising. Antibiotics were upgraded to broad spectrum peptides. Again, day 10 and TLC were rising and teicoplanin was added. Initial blood culture and urine culture were sterile. However, on day 10, the oxygen requirement were reduced. Chest X-ray started showing improvement. Fever subsided. Even the TLC also started declining. So there must be some secondary infection that has responded to the antibacterial agents. The day 14, COVID RT-PCR became negative. Patient was shifted to medical ICU. Antibiotics stopped. But after 4 days, when the patient was receiving supportive care, TLC again rose to 26,000 with a high-grade temperature. Now, even after 10 days of antibiotics, after initial improvement, there was rising fever and TLC. CRP was high, but the procalcitonin, which is a marker of the bacterial inflammation, is not normal. D-dimer was also normal, ferritin was mildly raised, and IL-6 was raised. So the classical factors, diabetes mellitus, steroids, and the catheter. There has been ICU stay of more than 7 days, critical illness, and persistent fever even after 10 days of broad spectrum antibiotics. Now, what we thought, it could be some fungal infection. So cultures were sent for fungal workup. The urine culture, budding yeast cells were grown, which shows Candida auris, and the blood culture again showed Candida auris. So there was a COVID-associated candidiasis, that is invasive candidiasis, and we all know that is Candida auris is a superbug among the fungal community. Normally, the Candida are the normal commensals, but the classical risk factor like diabetes, steroids, catheter, total parenteral nutrition, in multiple antibiotics, ICU stay more than 7 days, hemodialysis preceding invasive candidiasis, Candida colonization, all these increases the propensity of invasive candidiasis. Use of catheter promote the entry and leads to biofilm formation. Mechanical ventilation increases the risk of colonization. Sepsis, septic shock leads to translocation of Candida from gut into the systemic circulation. So all these factors may lead to increased incidence of invasive candidiasis. So COVID-19 is also a similar kind of illness, but we ignore such infections. Such infections should not be ignored. So this is the study conducted very early during the first wave. Multi-drug resistant Candida auris, and India reported around 2.5% of the cases of the Candida infections, not only Candida infection. And again, the risk factors were antibiotic use, catheters, steroids, etc. So 2.5% nosocomial candidemia was noticed, 15 out of 596 cases. 10 patients, 67% were the Candida auris in bloodstream and 2 were Candida auris in urine. And the 70% of the auris isolates were multi-drug resistant, 100% resistant to the commonly available fluconazole. And the Candida auris mortality was 60%. So again, these kind of infections should not be ignored and should be thoroughly worked up. So this is the case. These are the studies which reports invasive candidiasis from the COVID patient. UK around 12.6%, Italy 8%, etc. So the overall data shows that there has been increase in invasive yeast infections among critically ill COVID-19 patients. Candida albicans was the most prevalent species, and most of these isolates were multi-drug resistant with very high mortality. Now coming to another last case, 47-year-old post-COVID obese female. Course during COVID illness, there was a moderate disease, received steroids, heparin, BiPAP support, gradually weaned off, but became oxygen dependent with 3 to 4 liter oxygen requirement. Now, in view of the persistent oxygen requirement and the post-COVID fibrosis, she received prolonged course of steroids. HRCT revealed post-COVID organizing pneumonia and fibrosis, so she was started on pirfenidone. Post-COVID, day 45, there was sudden onset of fever with leukopenia and transaminitis. So again, in view of some infection, she was admitted. Broad-spectrum antibiotics, meropenem was started. However, initial workup, procalcitonin, blood urine culture, fungal workup was negative. After 5 days of onset of fever, there was increase in stool frequency, 15 to 20 episodes with frank blood in stool urgency. So what could be? It could be diarrhea, it may be antibiotic associated diarrhea. So metronidazole was added, but the workup for Clostridium difficile was negative. There was no improvement. So the fever, leukopenia, transaminitis, colitis, rectal bleed in the background of immunosuppressed condition. CMV was thought, and CMV PCR was sent in blood, and it showed a high copy number. So diagnosis of CMV was made, that is a cytomegalovirus infection. Antiviral gencyclovir was started, antibiotics stopped, and within few days, fever, diarrhea subsided, blood parameters improved, and she was discharged. So while we were dealing with the post-COVID mucormycosis epidemic, there was again an alarm from the news that 5 COVID patients at Delhi Gangaram ICU's hospital suffered rectal bleeding due to CMV infection. Similar cases were reported from the Apollo hospital. So why there was CMV infection? CMV is usually a latent virus. It is acquired in the childhood and established latency in mononuclear cells and organs like lungs and gut. Their worldwide prevalence is very high. It is around 100%, while in CMV reactivation can occur intermittently throughout the life. And asymptomatic viral shedding is common in urine, saliva, but the vigorous immune response in our body prevent this over clinical manifestation. Reactivation of latent virus can lead to severe disease in immunocompromised patients, and it can present with the clinical syndromes like encephalitis, pneumonitis, hepatitis, uveitis, etc. Mechanism of reactivation has been linked to cytokine storm associated with the critical illness, probably the immune dysfunction again, and lungs act as a most consistent site for reactivation. So this is again an alarming secondary infection which should not be ignored. So the risk factor associated with the reactivation of the CMV is immunocompromised condition, mechanical ventilation, sepsis, and the steroid use. But the reason for CMV infection in COVID or post-COVID patients, again, immune dysfunction, prolonged mechanical ventilation, and use of steroids and immunosuppressant. So here I end my talk with the take-home message that multiple factors in COVID-19 illness can lead to secondary infections. There should be judicious use of steroids, immunosuppressants, and even antibiotics. A patient can have plethora of the secondary infection, which should be carefully worked up and evaluated. More than one secondary infections and sequential infections are possible. Now, coming to my first case of the post-COVID vancomycin-resistant necrotizing pneumonia. After patient improved from this necrotizing pneumonia, 1 month after improvement, again patient landed up in invasive aspergillosis. And similarly, in my case too, while the patient was being treated for pulmonary aspergillosis, he now developed pulmonary TB. So there is possibility that one infection can occur after another infection, and more than one secondary infection is possible. Sometimes it becomes difficult to differentiate between colonization and infection, but it is a need of our to differentiate appropriately so as to avoid the use of antibiotics, and timely and appropriate diagnosis can save life. Thank you.
Thank you, ma'am. Thanks a lot, Chavi ma'am. Actually, a few questions came in my mind. If you permit, I would like to ask the question. Well, ma'am, first question is you talked about secondary infection.
Yeah.
So the question is how we can suspect possibility of secondary infection in COVID-19.
Ma'am, it depends totally upon the clinical presentation of the patient. As you have seen that in CMV case, there were pointers like the patient, and obviously after the complete workup is required. You cannot jump only to a one diagnosis and work up according to one etiological agent. We have to work up holistically. All bacterial, tubercular, fungal, viral, every infection has to be evaluated, and appropriate test has to be done. What is CMV infection? After ruling out bacterial fungal infection, we thought that there could be now there were pointers of clinical symptoms like fever, transaminitis, rectal bleed, which were pointing towards the CMV. So we ordered CMV PCR. Similarly, in first case where we sent pus culture for all possible workup and we grew VRE. So it is depending upon the clinical scenario, we have to judge or order test for the secondary infection.
Thank you, ma'am. Another question came in my mind because I was watching today's highlight, and in the highlight there were a name, only single name, Omicron. Can you? I want to know actually, being a common man, I want to know, is it more serious than Delta infection, which
Ma'am, it is too early to comment on this. Nobody is
Okay.
aware of this presentation, even if they are saying that the South Africa, it is not having that, obviously the rate, since there is increase in transmissibility, that it will affect more people. But now again, South African ethnicity and Indian ethnicity is different. So we cannot say anything. If even if you have noticed during the first wave, our mortality in our country is less, but in European country it has created a havoc. So, and in second wave there was more mortality. So it's too early to comment, and one country cannot be extrapolated to other.
Thank you, ma'am. Thanks a lot. Ma'am, I would like to share this certificate of appreciation to you.
Thank you so much.
As because of all this social distancing, right now we cannot give you, but definitely in future we'll come and share with you its hard copy. Thank you.
You so much.
Thanks a lot, Hcv ma'am. Thank you.
Thank you.
Thank you, ma'am. So now going forward, now moving forward with a very good message by Hcv ma'am, and very good this. And now I'm going ahead for the next CME topic of this day is HbA1C, unit number and method. And this will be covered by Dr. Barnali Das. She is currently the consultant laboratory medicine at Kokilaben Dhirubhai Ambani Hospital, Mumbai. She is also executive member, scientific division, International Federation of Clinical Chemistry and Laboratory Medicine. She is also chair, American Association of Clinical Chemistry, Indian section, and NABL assessor and College of American Pathologist Inspector. So I'd like to call Dr. Barnali Das. Over to you, ma'am. Please welcome her. Please unmute yourself, ma'am.
Thank you, Mrs. Vidhi Jain, and thanks for the kind introduction, and thanks Mela and Medical Education and Learning Point and Dr. Neeraj Jain for inviting me and giving me this opportunity to talk in front of this esteemed audience. So now I'll share. You can see my screen.
Yes, ma'am.
Thank you. So today my talk is on glycated hemoglobin, HbA1c unit numbers and method. So I'll share with, some of our case studies, like how we have interpreted, and some of the case history of hemoglobin. How it interferes with HbA1c. Can you please, can you ask others to mute? So this, for us diagnosticians, every blood sample tells us a story. So this is one of our my painting. So we realized during this, like Dr. Chabi presented, we realized during this COVID time that the role of the diagnosticians, usually we used to think they are behind the curtain, but now we realize like how much contributions diagnosticians have in this, and also in the routine diagnosis. So this is one such, like diabetes, we know is kind of becoming epidemic, and so because of that, every blood sample for us counts. And being executive member of scientific division of International Federation of Clinical Chemistry and Lab Medicine, IFCC has done a lot of work in harmonizing and standardizing HbA1c, because we know different methods. Every day you must be, who are in the diagnostic lab, every day you some diagnostic manufacturer must be coming to you with different kits. So which kit is gold standard, and what to do and how to interpret is a really challenge. So I will share IFCC's perspective also and a perspective. So we know 14 November 2021 is World Diabetes Day, and this year the theme of World Diabetes Day is access to diabetes care. And why we need that? So over 530 million people are now living with diabetes worldwide in 2021. Prediction 2030, 640 million, and 2040, 780 million worldwide population with diabetes. So many do not have regular and affordable access to the fundamental components of diabetic care. And we know 14 November 1921, Benting and Best presented their research, which led to first successful use of therapeutic insulin in January 1922. So over 100 years later also, it's seen that it's millions of people living with diabetes lack access to the ongoing care, support, and they require to manage their condition and avoid complications. So this is kind of unacceptable, but it's true worldwide. So in 2019, diabetes was 9th leading cause of death, with an estimated 1.5 million deaths directly caused by diabetes, and its complication can lead to heart attack, stroke, blindness, kidney failure, lower limb amputation. And in April 2021, WHO launched the Global Diabetes Compact, a global initiative aiming for sustained improvements in diabetes prevention and care, a particular focus on supporting low and middle income countries. And in May 2021, World Health Assembly agreed on a resolution on strengthening the prevention and control of diabetes. So coming to the classification, because just to update a little bit about the classification diagnosis of diabetes and like standard of medical care in diabetes 2021. So diabetes classified like following general categories: type 1 diabetes due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency, including latent autoimmune diabetes of adulthood; and type 2 diabetes due to progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance. So this is due to insulin resistance, we see type 2 diabetes. Specific types of diabetes due to other causes like monogenic diabetes syndrome, such as neonatal diabetes, maturity onset diabetes of the young MODY, and disease of exocrine pancreas such as cystic fibrosis, pancreatitis, and drug or chemically induced diabetes such as with glucocorticoid use in treatment of HIV/AIDS and after organ transplantation. And the gestational diabetes is diabetes diagnosed during second or third trimester of pregnancy that was not clearly over diabetes prior to gestation. So type 1 diabetes and type 2 diabetes are heterogeneous diseases in which clinical presentation and disease progression may vary considerably. So classification is important for determining therapy, but some individuals cannot be clearly classified as having type 1 or type 2 diabetes at the time of diagnosis. So this is given in 2021, the standard care in diabetes, this classification. The traditional paradigms of like type 2 diabetes occurring only in adults and type 1 in children are no longer accurate, as both diseases occur in both age groups. And children with type 1 diabetes typically present with landmark symptoms of polyuria, polydipsia, and approximately 1/3 patients with diabetic ketoacidosis. And the onset of type 1 diabetes may be more variable in adults. They may not present with the classical symptoms seen in children and may experience temporary remission from the need for insulin. So occasionally, patients with type 2 diabetes may present with diabetic ketoacidosis, particularly ethnic and racial minorities. It is important for the provider to realize that the classification of diabetes type is not always straightforward at presentation, and that misdiagnosis is very common, or sometimes missed diagnosis also. So like adult with type 1 diabetes misdiagnosed as having type 2 diabetes, individuals with maturity onset diabetes of young misdiagnosed as having type 1 diabetes. So although difficulties in distinguishing diabetes type may occur in all age group at onset, the diagnosis become more obvious over time. So HbA1c or glycated hemoglobin, we all know this is the hemoglobin with which is glycated at the end terminal of the beta chain of hemoglobin, and two steps of formation, like formation of L-dimin unstable shift base labile A1C or pre-A1C, which is reversible, and conversion of shift base to form stable ketoamine HbA1c. So it reflects 1 to 3 months of average glycemic control or blood glucose level, and is very important in diabetes control and prevention of complication. So we all know the glycated hemoglobins are A1A, A1B, and A1C, but main glycohemoglobin is A1C. It is used over more than 20 years. And now the recommendation, why we need glycated hemoglobin or HbA1c. So to avoid misdiagnosis and missed diagnosis, so the A1C, like you saw, the classification, like in 2021, the classification also suggests that sometimes type 1 diabetes misdiagnosed or as type 2. So because to avoid this misdiagnosis and misdiagnosis, A1C should be performed using a method that is certified by NGSP and standardized to the DCCT, Diabetes Control and Complications Trial, DCCT-SA. So what are the advantages? Why we should not go for fasting plasma glucose or oral OGTT, oral glucose tolerance test? So because HbA1c greater convenience, fasting not require one-time prick, and greater pre-analytical stability and less day-to-day perturbation like during stress, changes in diet or illness. And when we see the disadvantage, maybe when sometimes we see discordance between the A1C value and plasma glucose level, then there may be possibility of A1C interference by hemoglobinopathy, and then the assay without interference of plasma glucose of hemoglobinopathy, the A1C assay, or plasma glucose criteria, we can use HbG and OGTT to diagnose diabetes. So in condition associated with altered relationship between A1C and glycemia, such as hemoglobinopathies, sickle cell anemia, second and third trimester of pregnancy and postpartum period, G6PD deficiency, HIV, hemodialysis, recent blood loss or transfusion or erythropoietin therapy, only plasma blood glucose criteria should be used to diagnose diabetes. In all those conditions, we should not use A1C, we should use plasma blood glucose criteria for diagnosis of diabetes. So what is a desirable? When we see less than 5.7 is desirable, but when we see between 5.7 to 6.4%, so there is increased risk of diabetes. Then A1C non-diabetic individual, actually we say that as less than 6.5%, and in patient with diabetes mellitus, the desirable is less than 7%. And when we should consider adjusting treatment if it is more than equal to 7%, and when we need, definitely we should adjust the treatment more than equal to 8%. And wow, what is this? This is today's scenario. So because of globalization, our endocrinologists, our physicians are seeing a lot of patients for many different countries. So some country may be reporting the HbA1c millimole per mole, and some many of us are reporting in NGSP percentage. So one person during the similar time, maybe in 1 month period or maybe few 15 days period, getting 3 different values from 3 different labs, and one in millimole per mole, one in percentage, and our lab has given HbA1c can't be reported because there may be chance of hemoglobinopathy. So what do you think? Why there is so much variation? So this is the cartoon of today's lab system. If you see, the patients are coming with burden of disease, and inside our lab, what we do, we use our intelligence, discipline, and creativity. I mentioned that this 3, even creativity is important to implement inside lab. And we use all the 3 components. And here the patients are going with reports, and either they are happy, or either our clinicians are happy, or sometimes endocrinologists may be giving you call that Barnali, I'm seeing these patients, I'm not happy with this result, and or Barnali, this patient has some results from outside India and reported as millimole per mole. So will you convert it for me? So, and if you see this person, this may be you or me as an ABL assessor or CAP, College of American Pathologist inspector. We go to different lab, we see the process, like Dr. Neeraj Jain during the inauguration, he said, like harmonization, standardization, accuracy, precision. So we go and we see the process for 1 day or 2 days, and based on, or sometimes if you say NABH or JCI, the hospital accreditation, they come and they see our process, suppose glucometer monitoring, and they see the quality control process, IQC and all. Based on that, we raise the deficiency or non-compliance. So let's see why there are so much variation. So do you think which report is correct? Do you think we should report in millimole per mole, or do you think we should report in NGSP percentage, or do you think the report where they may mention that it can't be reported because there is possibility of hemoglobinopathy? Why there is so much variation? So I believe in the philosophical lines of Albert Einstein, life is like riding bicycle. To keep your balance, you must keep moving. So similarly, in our lab life, what is important, why the method is important, why we should think that which method we should choose, like which, because nowadays we know POCT diagnosis of HbA1c, even in instrument we are getting different instrument, different assays, different methods, we are getting HbA1c. So which one we should choose? So because of that, accuracy, precision, and cutoff or reference interval verification, validation, very important. And there is, this is one wheel is wheel of quality, and another wheel is wheel of cost, where this is very important, man, machine, and material. So we should have the balance. Like suppose this is a diabetic clinic, and which the clinicians want to do the test. So what you will recommend, or as a diagnostician, what methodology and what test and how to do the test, how you will recommend. So and is it POCT HbA1c recommended or not? Let's see during my talk. So because of that, verification, validation is very important, and harmonizing and standardizing our reports are very important. So coming to standardization, standardization means when we have primary reference measurement procedure and we have complete or full meteorological traceability, and harmonization when we don't have a primary reference measurement procedure, when we have only manufacturer master measurement procedure. So then we can't standardize that test, we can only harmonize that test, like define, measure, and units, and then you do the all-purpose trimmed mean, and between the method and method comparison you can do. So that is partial meteorological traceability. We can do the harmonization for that. So why we should harmonize? Because of patient safety, because of patient empowerment, public confidence, accreditation, clinical guidelines, clinical governance, consolidation and networking, informatics, and electronic patient record. So what we are reporting, so we need to harmonize the total process. And now coming to units, because during the first slide I showed that how units can make confusion. So because of that, we need to have the harmonization of units. The test name used in the reports should comply with the international system and lab terminology. Ideally, units should be in line with the international system of units. So let's see the challenge in HbA1c reporting. So we know NGSP or American Diabetes Association, they recommend to report in percentage A1C. Like India, most of the labs are reporting in percentage. So that's like A1C in gram per deciliter divided by total hemoglobin in gram per deciliter into 100. And IFCC recommends A1C to be reported in millimole per mole. So many European countries have shifted to IFCC millimole per mole along with EAG reporting. So what is the difference? If you see the difference, if you see in NGSP percentage, we are reporting 6%, and this is like one digit, and when we are reporting in millimole per mole, it's 41 millimole per mole. So 2 digits. So this is the change. And 6.5% is 48 and 7% is 53 millimole per mole. So what is NGSP? NGSP is National Glycohemoglobin Standardization Program implemented in 1996. It establishes the traceability of the A1C results to DCCT based on HPLC reference method that was used in DCCT. So this was long back. But then IFCC started harmonizing hemoglobin A1C testing. So IFCC working group on HbA1c standardization developed reference method for HbA1c analysis, and to achieve uniform international standardization, this working group was there in 1995. It was established, and in 2010 they have fulfilled their mission of recommending millimole per mole, so it ended. So now coming to what is our role. So this is like the NGSP percentage, and this is the formula for like if suppose some patient is coming with millimole per mole result. So this is the formula to form conversion in millimole per mole to NGSP percentage. And IFCC has primary reference material for calibration of reference method, mixture made by pure HbA1c and pure HbA0. So there is reference method, and the gold standard is HPLC. And the principle is the first step, hemoglobin is cleaved into peptides by proteolytic enzyme, and thereafter the specific glycated and non-glycated N-terminal peptides of the beta chain measured by HPLC and either mass spectrometry or capillary electrophoresis. So these are the gold standard. And so NGSP and IFCC, the numbers, so there is a big debate. If you in 2007, IFCC recommended IFCC HbA1c expressed in millimole per mole, and this is more accuracy-based results if we are reporting in millimole per mole, and NGSP results can be directly related to clinical outcomes and diabetes care goals. Like if you see American Diabetes Association guidelines and goals, ADA recommends to report in percentage. So although IFCC and NGSP correlation is excellent, the absolute numbers are different. There are much debate over which numbers should be reported worldwide. So IFCC results are consistently 1.5 to 2% HbA1c lower throughout the range of the values. Now our rule, I am sitting in my lab, you are sitting in your lab. So how you should report? So ADA recommends and EASD and IDF, they have defined the mathematical relationship between HbA1c and average glucose, EAG, estimated average glucose. This can be calculated by this formula, estimated average glucose. So if you have in your table this table only, IFCC HbA1C millimole per mole with NGSP conversion in percentage along with estimated average glucose in milligram per deciliter and one estimated average glucose in millimole per liter. So you can report any report in any of the units. And another thing, if you can implement this formula in your electronic medical record or EHR or LIS, so it will come for our system, it comes directly, we get both the values, and I'll show you our reports. So officially worldwide consensus that HbA1C should be reported in both NGSP percentage and IFCC millimole per mole units along with estimated average glucose, that is millimole per liter or milligram per deciliter. However, the decision on what to report is actually being made country by country. So in India, we are still reporting in percentage, but tomorrow, maybe 2 years down the lane, it will come that report in millimole per mole. So in US, reporting in NGSP percentage and HbA1C along with EAG has been recommended by ADA, American Diabetes Association, or American Association of Clinical Chemistry. Some other countries have also decided most will report IFCC, and some country has decided that they will report IFCC and NGSP both, and some will switch to IFCC only. So this is like Europe, we see mostly reported in millimole per mole, and in US we see in percentage. So what we should do, I feel we should report in both millimole per mole and percentage. So it becomes easier for the endocrinologist, it becomes easier for patient also if they travel different countries, and so it's just easy. So we know the methods, different methods like HPLC, ion exchange chromatography, capillary electrophoresis, isoelectric focusing, enzymatic. These are based on charge differences, then based on structural differences, affinity chromatography, immunoassay, and based on chemical analysis, photometry, spectrophotometry, immunoturbidimetry. So these are different methods. So these are different like HPLC assays, immunoassays, enzyme assays, and these are different principle and different features. Like HPLC is gold standard, but immunoassay is low cost, high specific reaction, and high throughput, and immunoassay and enzyme assay. And so because of that, many automated lab and high workload of HbA1C, they shifted to the immunoassay or enzyme assay platform. And many countries where hemoglobinopathies and many regions where hemoglobinopathies are prominent, so HPLC or capillary electrophoresis is one of the better method because we can know about hemoglobinopathies. So this is what is the NGSP certification process. There are NGSP, we know, national glycohemoglobin standardization program in US, and 3 types of certification. Manufacturer certification. So when any vendor comes to you, then check with the NGSP certification, or is it traceable to DCCT or not, your A1C results. And there is also level 1 lab and level 2 lab. So individual lab can also have NGSP certification. So many clinical research organizations go for that. So what we should harmonize and standardize our protocols, our parameters, our methods, and test requesting, sample handling, reporting at the local level, and lab parameters like test names, units, reference intervals, critical values is at local level, national level, and then technology traceability like NGSP traceable, DCCT traceable, commutability, this is at local and international level. So this is one of our report for how we started reporting. So glycated hemoglobin, then this is HPLC method. We report in percentage, NGSP percentage, and also we report in millimole per mole. And we give the biological reference interval both with NGSP percentage and millimole per mole. Also, we report average glucose value in milligram per deciliter and millimole per liter. So this is, we have, for our patient, we give both the units for our patient. And now coming to the criteria for diagnosis of diabetes and pre-diabetes. So fasting plasma glucose more than equal to 126 milligram per deciliter. So fasting is defined as no caloric intake for 8 hours, at least 8 hours, and 2 hour post glucose that is more than equal to 200 milligram per deciliter or 11.1 millimole per liter during the OGTT. The test should be performed as prescribed by WHO using glucose load containing equivalent of 75 gram of anhydrous glucose dissolved in water. So remember that, because this is one of the criteria. And or A1C more than equal to 6.5% or 48 millimole per mole, and the test should be performed in a lab using method that is NGSP certified and standardized to DCCT, or in patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose more than equal to 200 milligram per deciliter or 11.1 millimole per liter. Now for generally fasting plasma glucose 2 hour post glucose during 75 gram OGTT and HbA1C are equally appropriate for diagnostic diagnosis purpose. It should be noted that tests do not necessarily detect diabetes in the same individual. The efficacy of intravenous efficacy of the interventions for primary prevention of type 2 diabetes has mainly been demonstrated amongst individuals who have impaired glucose tolerance or with or without elevated fasting glucose, not for individuals with isolated impaired fasting glucose, or for those with pre-diabetes defined by A1C criteria. The same test may be used to screen for or diagnose diabetes and to detect individuals with pre-diabetes. Diabetes may be identified anywhere along the spectrum of the clinical scenarios. And like in seemingly low risk individuals who happen to have glucose testing, in individuals tested based on diabetes risk assessment, and in symptomatic patients. So fasting and 2 hour plasma glucose may be used for diagnosis of diabetes. I said some of the conditions where we see interferences. The concordance between fasting plasma glucose and 2 hour post glucose test is imperfect. When we see the imperfection or there is discordance, then we should do A1C, and the concordance between A1C or either glucose-based test should be monitored. So this is pre-diabetes, like fasting plasma glucose between 100 to 125 milligram per deciliter. This is impaired fasting glucose, or 2 hour plasma glucose after the 75 gram OGTT is 140 to 199 milligram per deciliter. This is impaired glucose tolerance, or A1C value 5.7 to 6.4%. So there are two primary techniques available for healthcare providers for monitoring this glycemic control and assess the effectiveness of management plan and glycemic control. That one is patient self-monitoring of blood glucose, SMBG, or interstitial glucose, and A1C. So how frequency, what should be the frequency? A1C tests performed at least twice yearly in patient meeting the treatment goals and have stable glycemic control, and perform A1C quarterly in patients whose therapy has changed or who are not meeting glycemic goal. So the recommendation, glycemic goal in adults lowering A1C 2 or below or around 7% has been shown to reduce microvascular complications, and if implemented soon after the diagnosis of diabetes, is associated with long-term reduction of macrovascular disease. Therefore, a reasonable A1C goal for many non-pregnant adults may be less than 7%. So providers might reasonably suggest more stringent A1C goals, such that less than 6.5% for selected individual patients, if this can be achieved without significant hypoglycemia or other adverse effects. So appropriate patients might include those with short duration of diabetes, long life expectancy, and no significant CVD or cardiovascular disease. Less stringent A1C goals, such as less than 8%, may be appropriate for patients with history of severe hypoglycemia, limited life expectancy, advanced microvascular and macrovascular complications, and extensive comorbid conditions. So those with now let's see which pilot you will choose. Suppose we were going for your vacation flight to your dream destination. So which pilot you will choose? You will choose this one. Of course, you want to land on the runway, right? After COVID, we all want to go for a vacation to our dream destination. So we want to land on the runway. Yes, of course, he lands on the runway. But if you see the second pilot, he is always near the target. So as I have shown in my previous, that cartoon, that variation in HbA1c results, and a clinician is really puzzled, or endocrinologist is thinking which lab result to believe. One is in millimole per mole, another is in percentage, 11.2%, and another lab is giving HbA1c can't be reported because there is chances of hemoglobinopathy interference. So which pilot you will choose? Our clinicians or our patient doesn't bother much about which Westgard rule we are implementing in our lab. What they are bothered, they bother that their value should be near target. That value should be clinically near the target, and clinically value, it should add the value. So this is like we are the pilot, and our patient, our clinicians, executive and executive health checker, they are the passengers. So they doesn't want, only to meet the specification, like 2 standard deviation or 3 standard deviation. They want the value should be near the target. So that means we need to change our habits for reporting. So suppose you are having some, we have, I think, verified or validated around 8 manufacturers for HbA1c. So whenever it's not any method is good or any method is bad, so then whenever you are you are starting one new method, you should do proper method comparison with the gold standard, and we should check, because we see many of the patients with hemoglobinopathy, and we should check between in hemoglobinopathy how the reports are given and what is the comparability. So this is our method comparable study, and we have compared in 160 samples along with 60 samples for hemoglobinopathy, and our value was more than 0.975, so we accepted that. So the methods, these are different methods. The question therefore arises, which route is to be chosen? So this, I will, I think I have a couple of 15 minutes more. So this is little bit case study I will discuss. So suppose I am reporting chromatogram. So as a biochemist, as a pathologist, we should know, a diagnostician, we should know how to report. Even technical person should know, like if there is any hemoglobinopathy, if you are reporting through HbA1c or if you are reporting through capillary electrophoresis, we should know how to interpret. And even the technical staff should know, if some diagnoses are missed or not. So for them, for us also, this is like baseline should be properly constructed for chromatogram. It should be straight line, peak shape, sharp and symmetrical, total area between 1 to 5 million, and results should not be reported if the area is outside the range, and the sample should be manually pre-diluted if it is outside the range and redone. And for some high total area like high HbA1c 15% or HbA1c or 140 millimole per mole HbA1c with 5 million total area, A1c peak may be eluting outside of the established retention time window. So because of that, we need to pre-dilute the sample, and then we should run. And so the result review, what criteria we should observe, like its total area should be between 1 million to 5 million, A1C, A0 peaks correctly identified, A1C and A0 retention time, consistently in range, refer to the current cartridge, pack insert. It's very important to see the pack insert for retention time and window. Then F peak should be less than equal to 10%. Labile A1C or carboxylated hemoglobin should be equal to less than 4%. A1C results within reportable range, baseline properly constructed, A1C peak shape, sharp and symmetrical. And reportable range, now coming to reportable range. NGSP recommends reportable range 3.8 to 18.5%. And IFCC recommend 18 to 179 millimole per mole. So beyond that range, any sample actually more than 15%, if it is showing HbA1C, should be suspected of having hemoglobin variant. So HbF less than equal to 4 or 10%, and this already I have said. If there is a variant window, variant and S and C windows, combined area more than 60%, you should suspect of having homozygous variant. If there is homozygous variant, then it should not be reported. So we know this, and I will not go into details because we know how to interpret. And sometimes HB loose with A2 and HBD, there is an unknown peak at 3.8 plus minus 0.1 minute. HBS showed as S window, HBCC windows. So generally 22 to 40% heterozygous, 70 to 90% homozygous. In any homozygous, we should not report A1C. And if we see compound conditions, then also we should not report A1C. Only heterozygous cases we can report A1C value. And HBJ Mirat, like alpha gene variant P3 between 15 to 25%. HBQ India, we see unknown peak between 4.5 minutes retention time. And so this is one patient. If you see, some lab has reported as 6.6 HbA1C. And if you see here, the unknown peak is 51.6. So any variant window we should check with a dual mode, and A1C, any variant window, if it is less than 60%, run on the dual mode. If D trait or E trait, HbA1C can be reported on the dual mode, but if it is compound heterozygous, it should not be reported. So this is by capillary electrophoresis is showing atypical profile. And this is for this patient, if you see, unknown is 51% and at retention time 3.87 minutes. And here, if you see, HbA2 is 4.9. So here, how we have reported hemoglobin HPLC reveals an unknown hemoglobin eluting with a retention time of 3.87 minutes, and it comprises of 51% of the total hemoglobin, and HbA2 is 4.9% is raised. Maybe this is due to artifactual, and HbA normal adult hemoglobin is 33.1%, and HbF is not elevated. So it is not possible to give definitive opinion in this patient, but we should do molecular studies to rule out compound heterozygous state of HBD, Punjab, and beta thal. So this is kind of reporting we do, but it's when it is done by automated instrument, some other patient got the report of 6.6. So in this case, we have reported that glycated hemoglobin we can't report, although it has come 6.2 because there is a compound heterozygous state, and which can't be reported because D trait and beta thal. So because of that, we should do it. We should depend on the FPG, fasting plasma glucose, and OGTT, or advise serum fructosamine, because in this patient, fructosamine is not interfered. So wow, this is this fairy is telling, oh, I'm blood sugar fairy. If you can see me, yours is too low. So this is actually our today's scenario. So Any variant window on A1C mode can't be reported if the variant window less than 60% run on the dual mode. So this is another. If you see, the variant window in this case is 38.2, and this is at dual mode at 3.92 retention time. There is like 38.4%, and because of that, this is HBD Punjab heterozygous, and this can be reported. In this case, A1C is 5%. This can be reported on the not the A1C mode value, the dual mode value can be reported in this patient because this is D trait or HBD Punjab heterozygous. So this is another case. HbA1c of a known diabetic came 4.3% by other method of estimations, and age was 52 years, and sex male, and came for routine checkup, random sugar 97 milligram per deciliter, but it was known diabetic patient. And so here, if you see, this is S window 68.2%. So this is here HbS homozygous or sickle cell disease. So in this case, HPLC picked up, and we should do abnormal hemoglobin studies when we suspect this. Otherwise, sometimes we miss some of the cases. So this is HbS homozygous, and so if we report A1C 4.9%, this is a wrong value, and this is actually S1C, not A1C. So in those cases, there is no HbA present, and therefore no HbA1c value can be determined. So because this is a case, and here also there is a S window when we see even in A1C mode 38.2%, and if you see S window is 34.9% at dual mode. So this is HbS heterozygous, that is HbS trait, and here we can report when this is S trait, we can report value in A1C mode. So this is like how we should report, and this is the CBC picture: microcytic hypochromic red cells with HbS 36.5% and sickling test positive. So this is heterozygous state for HbS, and in this case S trait we can report HbA1c value because it doesn't interfere. So this is again another case, patient, a 16-year-old male, and this is again showing the HbF is here 76.7%, HbA2 4%, and A1B 15.3%. It may be HbF which is eluted here, and this is compound heterozygosity for beta thal and hereditary persistent fetal hemoglobin. This is 16-year-old male, and here this is the father's HPLC and CBC. So if you see father HbA2 is 4%, this is mother's HPLC, HbF 14%, mother's HPLC. So we should do the parents the hemoglobin, we should check for parents hemoglobin variants and hemoglobinopathies. And here HB compound, this is the case, this boy is the case of heterozygous beta thal HPFH, hereditary persistence of fetal hemoglobin. And because HbA1c value can be reported if presence of HbA up to 10% in D10, and if sample contains more than 16.5%, we should suspect that. And in this case, this compound heterozygous beta thal and HPFH, we should not report. So this 14-year-old recommended for A1C with patient obese, advised GAD and C-peptide level. If you see variant window 80.8%, and this is HBD homozygous, we should not report this. So I think the message is quite clear. So I will not move into the more details about more cases. So again, this is another case of HPJ variant. This is likely to be the alpha chain variant because of low HbA2 and raise P3. So I know data, and data. I can't make bricks without clay. So this is HbA1c reporting. We really need to see our chromatogram. If we are reporting by HPLC, we really should know how to interpret, and we should really check each and every chromatogram during reporting. And what is the advantage of other methods like automated methods? The advantage of those methods are that get the value, but when we see the prevalence of different hemoglobinopathies, then this is although legally maybe nobody, because you are doing by automated methods, nobody can question you, but some of the hemoglobin variants where maybe it's not HbA1c, maybe some other like I said HbS, when it was sickle cell disease, it may be not A1c, it may be S1c, so we may be missing. So, but there are two, like, this is like double-edged sword, how to report, and and also the medical legal complication of that. So because of that, we should careful when reporting. And as I will not go into details because Dr. Chabi has already told, during COVID-19 time, we saw that COVID-19 patients with higher HbA1c level may exhibit relatively higher level of severity, and the infection itself may also lead to increased A1C level. And the studies suggested that ARDS or severe acute respiratory syndrome patients, even those with mild symptoms who do not receive glucocorticoid therapy during the course of disease, had higher fasting blood glucose level, and HbA1c level of 66.7% patients was like when they were receiving like corticosteroid, a higher HbA1c value we see, of which 12.1% patients were newly diagnosed with diabetes. And for new onset diabetes patients, previously reported studies along with the study suggested of COVID-19 may cause and aggravate abnormal glucose metabolism. So the possible mechanism for COVID-19 causing abnormal glucose metabolism include islet beta cell damage and insulin resistance. And previous studies have reported some viruses can directly cause pancreatic beta cell damage, and angiotensin converting enzyme 2 ACE2 as SARS-CoV-2 receptor. We know the pathophysiology of SARS-CoV-2 entry, and this has higher expression in pancreatic endocrine tissue and exocrine tissues. So because of that, we see and these are already I have covered, like how to detect and where are the interferences we see, and the microvascular and macrovascular complications, and where we should interpret HbA1c with care, because the direction of the error, because hemolytic anemia decrease A1c, acute and chronic blood loss of pregnancy decrease, renal failure decrease A1c. So these are different interferences where we should be aware about that. And and average lifespan of RBC, because of that, we should not report when there is a abnormal hemoglobinopathy, because if you see the HbSS, only 17 days RBC lifespan. So because of that, it decreases. So because of that, we see the assay interferences in hemoglobinopathy. So this is, and fructosamine actually in hemoglobinopathy cases we can do, but fructosamine has again challenge, like it is not standardized, so not many standardized assay available. So because of that, you should report fructosamine with care. And glycated serum protein or glycated albumin is another better test, but again, it's not standardized. So because of that, till now, HbA1c is one of the gold standard. And I here thank all the staff of biochemistry and immunology team. And I here thank all of the participants, because you are the healer. If you see the clinicians, clinicians and surgeons and endocrinologists, they are treating the patients. But if you see this extended hand, that is yours, that is mine, that is ours. So we are the healer, and I salute and I acknowledge all the clinicians, all the diagnosticians during this COVID-19 time. Thank you. Thank you, Milap, and thank you, Jay Mitra and TIDE, for giving me this opportunity.
Thank you. Thanks a lot, ma'am. It was seriously very informative session. Ma'am, few questions are here for you. May I ask?
Yes, please.
One question one is HbA1c is used to monitor glucose for our previous 3 months. What is the role of diagnosis of diabetes? Role of it?
HbA1c now is gold standard for diagnosis of diabetes because it's fasting plasma glucose can vary, and like OGTT also 75 gram glucose, like many conditions it may vary, and because one single time fasting plasma glucose can raise anytime. So because of that, in diagnosis criteria, HbA1c is now diagnostic, and they are in the diagnostic criteria ADA has defined, and in diabetes care guidelines, it is now one of the gold standard for diagnosis as well as for diagnosis of diabetes as well as of pre-diabetes, and also for screening and sometimes for monitoring of microvascular and macrovascular complications, and to avoid microvascular and macrovascular complications in diabetes.
Okay, ma'am, thank you. And another question came in hemoglobin on pathologies, we get erratic results in HPCL. So what is the solution for that?
So because of that, is very important. Because of that, I showed the cases, actually case studies. So the interpretations, erratic results will, like whenever there is hemoglobinopathy, like I showed, the value was diabetic patients, the value of fasting and plasma glucose was very high, and non-diabetic cases, but the HbA1c value was 4.3 or 4.9%. So very much in normal range. So because of that, we should, in this discordant cases, HPLC, not HPLC, any method of HbA1c is not correct. So then we should suspect hemoglobinopathies. And for that reason, we should know, how to interpret. Because of that, I showed many of the cases, how to interpret heterozygous cases, how to interpret homozygous cases. And we should know, when we are reporting through chromatogram, in which heterozygous case we can report A1C value in A1C mode, and which case we should do it in dual mode, and we should check the A1C value.
One question came, ma'am.
Hemolytic anemia is decreased. I saw that one message. In hemolytic anemia, HbA1c value is decreased.
Okay, thank you, ma'am. Ma'am, one question.
Anemia, we should be very careful to report. So we should mention that there is interference due to hemolytic anemia. We should not rely on the HbA1c value.
Okay. Thank you, ma'am. Another question came in my mind, which is quite out of the box, because in my family, somebody is suffering with that. So I want to ask you that question. Question is, why thalassemia has not any recovery point? I think there are 2 kids in my family. That's why I want to ask it. Why this thalassemia is not recoverable? Because every month, every 10 days, we have to give them blood and everything. So transfusion and...
I can understand the difficulties with that, but some of the, recovery is maybe some days something and with bone marrow transplant and many of the things are, and this thing. So because of that, but yes, this is the challenge we face many times, like COVID-19. Many we lost many of the cases. So these are now there are therapy, and there are support group, and everyone is trying to help. So with that, we have disability nowadays. We talk about disabilities and all. So because of that, disability is not really disability. It's like our mindset, how we should accept that, and how anyone can do anything. This, I think we have to accept, and everything is possible in life.
Yes, ma'am. One more question asked by Dr. Chakshu Bansal. She asked, with can beta thalassemia treat affect HbA1c?
Yes, it will interfere with HbA1c, and we should report, we should report with a comment if we are reporting.
Thank you, ma'am. Thanks for very.
I can see several questions. If possible, I will answer. If you send me the questions, I can answer those.
Okay, so one more question came. Should the value of HbA1c below 5.7 so as not be pre-diabetic?
So as I showed in my slides, I showed the current one, the current diagnosis criteria for pre-diabetes. So I will share that slide.
Okay, please.
The diabetes criteria and HbA1c pre-diabetes criteria. So this is like I have shown in this slide. So I will share.
Please, ma'am.
Anything else? I think now this is tea time.
Yes, ma'am. We are going for the tea time, but before that, I'd like to call Dr. Neeraj Jain sir also, because we are going to.
I just let me answer 5.6 to 6.9 millimole per mole, or 100 to 125 is impaired fasting glucose or pre-diabetes, and 2-hour OGTT is between 140 to 199 milligram per deciliter. And as the question was about A1C between 5.7 to 6.4% is pre-diabetes.
Thank
so
you,
I showed that slide. Yes.
Yes, ma'am. Thank you. Thanks a lot. And we all would like to give you somebody given another question. May I ask you, ma'am?
No A1C less than 3.8%. Then that time you check if the patient is anemic or not, or any other hemolytic anemias or any other, like you should check the value of CBC, like actually hemoglobin. So just check the value and then interpret. Don't report 3.8%. We should not report. We should check, because 3.8% is one of the sensitivity range, the analytical sensitivity range. So if any value less than 3.8%, then we should check we should correlate with the complete CBC picture. So that may be you are reporting 3.8%, that may be wrong. So between if it is 3.8% and this is the analytical sensitivity for many of the HPLC method, so we should not report.
Thank you, ma'am. Dr. Chakshu Bansal also given a thanks message to you, and in the presence of everybody, I'd like to give you that appreciation certificate, as we cannot come to you right now and we are not physically present. So this is a certificate to you, and soon we will come to you with the hard copy of it. So please accept this certificate, ma'am.
Thank you so much. Thank you. And thanks everyone for attending this session, and thanks Milap and Dr. Jain, and thanks Jay Mitra, and thanks Vidhi. You are a very nice and very sweet host. Thank you.
Thank you, ma'am. So one information I'd like to share with you all who joined this session, that already I told you that TIDE-CME has been recognized by the Delhi Medical Council for credit points of 1.5 for all attending doctors. Link already I have given in the chat box. So please fill that form. And if you will fill that form, you will get that certificate also. So please go and fill that form. And Now we have 15 minutes more, so we are going to take a tea break with very sweet voice, which we were listening since 45 minutes. And I'm requesting everybody that please come before 5 minutes of 4 p.m. So it's a tea break, and we'll come
Thank
back.
you. And
We'll
I'm
get back
sorry I
later.
delayed the tea, I think, by 5 minutes.
No, ma'am, it's okay. It's okay. We have 15 minutes, so we can drink it. Thank you. Thank you, ma'am. Thank you, everybody. We'll come back to you before 5 minutes of OP. Thank you.
हाँ जी सर, हो गया हो गया हो गया। है nothing. इस सर ने एंड करोगे। ये
Yes, I'm going to share a feedback link again with you. Please check in chat box. I shared that link again. And please, all the doctors, please fill it. The answer for your question that for Chhattisgarh, it's is the credit hours application only for Delhi doctors? So I don't think so. It is the same. I think it's for all the doctors. But when Dr. Neeraj Jain will come, then we'll ask the same question with him. I think no. Yeah, I'm gonna to send the link again. Hi Monica ma'am, how are you?
Hi, कैसे हैं?
एकदम बढ़िया.
You have changed in that meeting, and now what I see you.
वो दिन गुरु के सामने थे.
बिल्कुल ठीक, बिल्कुल ठीक.
Neeraj sir, are you there?
अभी है नहीं मुझे लगता है.
हाँ, ठीक है. When he'll come, then we'll get the answer. Actually, the question was: is this credit is applicable for Chhattisgarh doctors also? This was the question.
अभी तो वो पूछना पड़ेगा.
हाँ, अभी उनको आने देते हैं, then I'll ask him. Okay.
ठीक है.
No issues. So, shall we start, ma'am? Are you ready?
As you say, if the time is
Yeah.
okay.
Time already completed. So 4 o'clock, 4 and 1.
ठीक.
So, welcome back you all, and thank you for this wait. I think you had taken your tea and say. Now, the third CME session is interpretation of hepatitis markers. And to share his incisive knowledge on the subject, we have Dr. Monica Jain. Dr. Monica Jain is the Chief Gastroenterology and Hepatology in Sri Balaji Medical Institute, Paschim Bihar, New Delhi. She has an experience of more than 25 years in the field of gastroenterology and hepatology. Very nice. She has been a guest speaker in various national and international conferences, though she is here also. She has around 32 publications to her credit. Dr. Jain, we are requesting you to take limelight and shed more light on the same subject. Please, ma'am, stage is yours, time is yours. Please start. Thank you, ma'am.
Thank you, Vidhi. I will be sharing my slides.
Please, ma'am.
Is it visible?
Yes, it is visible. Please, ma'am.
So the topic for today is interpretation of hepatitis marker. Basically, hepatitis is inflammation of liver, and we all know the liver is a major organ in our body, doing lot of functions, synthesizing proteins, protecting us from infections, and different metabolisms, they all are in liver. And hepatitis, once this occurs, this could be because of number of causes, maybe alcohol or non-alcoholic steatohepatitis, but one of the most common cause still remains the viral hepatitis, in which the inflammation of liver cells is caused by different viruses. Let's see what are the viruses which can infect liver. There are 5 main viruses: hepatitis B, C, D, and A. Out of them, A and E, they cause acute viral hepatitis, whereas B and C, they cause acute hepatitis, but later on, they go on to develop chronic hepatitis in the form of chronic active hepatitis, later on leading to cirrhosis, and some of them can develop ultimately hepatocellular carcinoma. Hepatitis D is an incomplete virus which acts only in the presence of hepatitis B. I will be covering this later. First of all, coming to hepatitis B. This is a virus which was first seen in patient of hemophilia, and this particular virus was named as Australian antigen because this was seen in Australian origin patient. But later on, this was renamed as HbV virus or hepatitis B virus. This virus is a very important cause of chronic liver disease in our country. So we must know how this virus is transmitted. The transmission of hepatitis B virus is very important to know the further how the patient is going to be affected. This can be transmitted through mother to child, which is known as vertical transmission. And the second mode of transmission is horizontal transmission, which is mainly through blood or blood products could be because of blood transfusion, infected syringes, needles, or can be due to sexual transmission. Why we should know about this transmission mode? Because the natural history of patients who acquire these infections in the childhood or horizontally is entirely different. So will be the profile of viral serology, which I will be discussing later. Let's see what happens if a person gets infection at the time of birth. Look at the chronicity rate. The person is not going to clear the virus in almost 90% of the cases. Whereas if this infection is acquired in older children or in adulthood, only 5 to around 10% of them are going to get chronic hepatitis. Whereas as far as the symptomatology is concerned, that is more when this is acquired in the older age group. Next comes what will be the natural history in such a case who acquires this infection at the time of birth. We all have read these phases of viral replication. The first phase is the immune tolerant phase, when this virus comes in the body at the time of birth. What happens? The virus is actively replicating. This is shown by hepatitis HbV DNA. ALT or SGPT is very high, but look at the inflammation. There is no inflammation in the liver. That means the body and the virus, they both are tolerating each other nicely. You must understand the virus, hepatitis B virus, does not cause liver injury. The liver injury is mainly caused by body's immunity against the virus. So in the immune tolerant phase, the DNA is high, ALT is low. That means virus and body are tolerating each other nicely. The second phase comes the immune active phase, when the body tries to take out the virus. So some sort of inflammation is there. So ALT level goes up. And this is the phase which is seen in the younger children in second or third decade, sometimes in more after third decade also. And the person comes as an acute hepatitis. Although when we will see the markers, we will come to know that this is not actually acute hepatitis. This is the ongoing hepatitis which was well tolerated. Now this phase has changed. During this immune tolerant phase, E antigen is high, and this is replaced by anti-E later on once the virus gets cleared. So this immune active phase is now changed to inactive carrier state. That means the person's immunity has reduced the amount of virus and now there is no inflammation. So this is known as inactive carrier state. And in this phase, E antibody, which is a marker of low replicative virus, and this is going to be high. Fourth phase is a reactivation phase, in which although the virus was low, but sometimes there is again inflammation which comes up, and this is known as reactivation. I am telling all these phases because when we will see the serological permutation combination, we will understand what is the phase of virus which we are getting. What is the natural history of this virus when this is acquired in adulthood? See, the 5% of patients, they go on to chronic hepatitis, whereas 95% they resolve the virus. They resolve the infection, and out of this 5 to 10%, around 15% they develop cirrhosis, and out of them 5% develops liver failure or liver cancer. So the difference between the acute hepatitis acquired in the adulthood versus the acute hepatitis which we had seen in the previous, this is the acute hepatitis which was there in the when the person got this virus at the time of birth, is entirely different because both will behave differently. So when we get a person who is hepatitis B positive state, what all comes in our mind? What is the age of virus? when the virus was acquired by the person. As we have seen, the natural history is different in both the groups. The second is, what is the replicative stage? That means the virus is there, but is it actively replicating, or it is dead, sort of dead or non-replicative? And what is the state of liver at the time of diagnosis? Sometimes what happens, the virus comes in the body and it makes the liver to go to cirrhosis and then becomes the non-replicative state. So the state of liver at the time of diagnosis or getting, when we come to know about HbS status, is very important. This can be done by simple ultrasound, fibroscan, and other imaging modalities. Lastly comes the family screening, because the family members of hepatitis B patients are, it is seen that the prevalence of Hep B infection in patients' family members is more, and so they should be screened and immunized accordingly to prevent the family transmission. Now, let's see what are the antigens and antibodies in cases of hepatitis B. The first antigen which is seen is a surface antigen, or very commonly known as HbS-Ag. The second comes the E antigen or HbE antigen. Third is a core antigen, which is known as HbC-Ag. And fourth is a HbV partially double-stranded DNA or HbV DNA. And then comes the DNA polymerase. So these are the antigens which are seen in patients. The combination of these antigens and their respective antibodies in case of surface, E, and core antigen will be seen, and let's see how they are interpreted. The surface antigen is there in a person who is infected with hepatitis B. This can be in acute phase as well as chronic phase. Surface antibodies, if they are there, that shows that the person is immune to this hepatitis B, because these are the antibodies which protect the person from further infection. Then comes the E antigen, which shows that the virus is replicating. Then the E antibodies shows that this is a low replicative state and the virus is not actively replicating. Then comes the core antigen. Unfortunately, we cannot detect this particular antigen in the blood. It is seen only in hepatocyte, but we can have core antibodies which can be there, which shows that the person had been infected with Hep B infection. Lastly, coming to HbV DNA. DNA shows that how much is the virus in the body, how much is the replicative status and activity of virus in the hepatocytes. Now, coming to the patient who has been infected with hepatitis B infection and is fully recovered. So what will be the serological profile? The first marker which will come is the HbS-Ag or surface antigen. This comes and becomes negative in most of the cases in around 6 months or 24 weeks. And this is replaced by surface antibodies, which comes around 32 weeks after the infection. So antigen comes, goes down, there's a gap, then antibody comes and it remains for the life. The second antibody, that is the core antibody of both the varieties, IgM as well as total core, they both increase, and IgM that comes down around 32 weeks, whereas total core or IgG variety that continues for the lifelong. So this shows when the person clears the virus, the antibodies are formed, and the second antibody is the core antibodies are formed. There is a window period, or this is the period when there is no antigen, surface antigen, and antibody has not yet developed. So how to diagnose this particular phase? This can be done by so showing the anti-HbC, that is the core antibody of IgM variety as well as total core. So if we can see both these antibodies, that means the person is infected with acute hepatitis B. About E antigen is basically an indirect marker of replication. So DNA as well as E antigen, they will be high in the acute phase, and they are replaced by E antigen is replaced by E antibody, and DNA becomes negative. So this is the profile, overall profile of the person who clears the virus. So ultimately, what is left once the viral infection is gone? One is a anti-surface antibodies, and the second is core antibodies of IgG variety or total core. Next comes what will happen if the person develops chronic hepatitis. So chronic hepatitis person will not clear surface antigen. So surface antigen will remain in the body. The total core will remain in the body. The E antigen will remain and may be replaced by anti-E antibodies depending on the replicative status of the person, and DNA may continue to be high or may come down depending on the viral status. So if we want to diagnose chronic hepatitis, the two important markers are there: the surface antigen will persist and the total core antibody will persist. So let's interpret what is the just a minute. Rohit, this upper end is not seeing this. I cannot see my slide properly. Sorry for the interruption because my slides are not seen properly. The upper end is not visible. No?
No issues, ma'am. Take your time.
Just a minute, because this is very important, because the upper end also shows one of the markers.
Yeah, please, ma'am.
Okay, abhi to theek hai. Now let's see what happens if the person, we will just see the permutation and combination of different markers, and we will interpret what is the interpretation of that. Let's see, when surface is negative, surface antigen is negative, core antibody is negative, total Y as well as IgM type, and there is no anti-surface antibodies. So this means that the person has never been infected with hepatitis B, and he or she is susceptible to this infection in the future. The second comes when the surface antigen is positive, the total core is negative, IgM variety of core antibody is negative, and there are no surface antibodies. This means either the person is in acute phase of infection when only marker which is positive is a surface positive, and rarely in patients who receive this vaccine, hepatitis B vaccine, it has been seen, this particular virus can be detected in the body for 2 to 3 weeks after this vaccination, although there is no clinical significance of that, but we should be aware of that. Just by looking surface antigen, we should not be jumping on the diagnosis of Hep B infection. Then comes the next scenario in which surface antigen is positive, total core antibody is positive, IgM core antibody is positive, but there are no surface antibodies. This shows all these markers can be positive in acute infection, and the patient has not yet cleared because the surface antibodies or seroconversion has not occurred. So this is an acute infection. Next marker is when surface antigen has cleared, the total core antibodies are there, IgM core antibodies are there and anti-HBs has not yet developed. That means this is a phase I have already described, a window phase in which the antigen disappeared, antibodies has not yet appeared, and the only marker which will be positive is total core or IgM core antibodies. Next comes the patient who does not have surface antigen, only the core antibody, total core is positive and anti-HBs is positive. Anti-HBs means the person has seroconverted. That means the person has past infection and has recovered and has developed immunity to this infection, and the person is immune to now next infection. Next comes a scenario when surface is positive and core is positive, IgM variety, and IgM total core is positive, but IgM is negative, and patient has not yet developed antibodies to surface. E antigen is negative and HbV DNA is negative. So the only marker which is present is a surface positive and total core. That means because the total core is positive, that shows the person is chronically infected. All the markers of activity, that is E antigen and DNA, they both are negative. So this is a non-replicative phase. That means the person harbors the virus but is not in active replicative phase. So next is the now coming to next case in which surface is positive, surface antigen is positive and core, total core is positive. This shows the person is having chronic infection. IgM core is negative. That means this is not an acute infection. Surface antibodies are negative. That means person has not yet developed immunity. And E antigen is positive, anti-E is negative, and DNA is very high. So this shows that the person is having, although this shows that the person is having chronic infection, and because although E antigen is positive and DNA is high, so this shows that the virus is actively replicating. So this is a chronic infection and replicating virus, and this is wild type. Wild means then whenever E antigen is positive, that is known as wild type of Hep B infection. Next case, when surface antigen is positive, total core is positive. This shows the chronicity, and the person, although has E antigen, there is no E antigen in the person, although the DNA is high. So this shows that the person, although is harboring the virus in large amount, but E antigen is negative. So this is a condition in which there is pre-core mutation. There is mutation in the pre-core region of the Hep B virus. So secretion of E antigen is defective. So in that case, the person will be having active virus, but E antigen will be negative. So this is a chronic infection, replicative phase, pre-core mutant type. Lastly, the person is having Hep B. There is no Hep B surface antigen. Only the core antibodies are positive. The IgM variety is negative and anti-HbA is negative. Only marker which is positive is a core, total core. This shows either the person is having low level chronic replication phase. Sometimes this can be seen in a mother to baby transmission, when passive antibodies can transmit from mother to baby, and this could be false positive also. This is the scenario when the person is only having anti-HBs antibodies. So this can be following vaccination, or patient can have this marker positive once he or she has received HbV immunoglobulin, then this stays for 3 to 6 months. Can we differentiate a person who gets this infection by natural infection or through vaccination? That means the person is having antibodies to surface antigen, but can we differentiate this is through natural infection or through vaccination? Yes, we can say if we have associated core antibodies that only develops when the person gets a natural infection, that means this is following infection and not the vaccination, in which only marker will be positive will be anti-HBs antibodies. This isolated anti-HBC core positivity, this is a report which comes many times from the blood bank. We get this report and they ask us, and this has been seen in around 10 to 20% blood donors in high endemic area and around 1% in low endemic area. So this shows that either the person had past infection and or acute HbV infection in window phase. Mainly this is important to understand. If this marker is positive, that person cannot donate blood or that person cannot donate liver. So mainly its role is there in organ donation or in blood donation. HbV DNA we can quantify by this PCR technique, and the significance of HbV DNA is in starting the treatment in chronic hepatitis B infection. When the level is more than 2000, let it be wide variety or we should start therapy when person is having chronic Hep B infection with level more than this. Treatment monitoring, especially in patients who are E antigen negative. In those cases, the DNA is the only marker which is monitored to see the treatment response. The treatment in pre-core mutant and reactivation of non-replicative HbV infection can be only assessed by HbV DNA, and diagnosis of HbV infection in fulminant hepatic failure. This is a condition in which there is massive destruction of hepatocytes. In those cases, sometimes it's very difficult to get any other marker other than only DNA, which can say that the pathology is due to HbV infection. Then comes the Hvv genotype. Almost we know about 11 genotypes, A, B, C, D, E, F, G, H, I, J, H. And out of them, in our country, we have A, C, and D. What is the clinical significance of this? The response to therapy. Well, previously, we were treating these patients with interferon therapy, and it was seen that genotype A was best responder. But now we have other drugs. So the response to therapy, how much will be the seroconversion, spontaneous seroconversion rate, the pre-core or core mutation status, how much the person will be progressing to cirrhosis, and what will be the incidence of HCC. All these parameters have been linked to HbV genotype, although presently the clinical significance of these markers is still doubtful. Recently, a lot of work has been done on HbS-AG quantification. Till now, we were doing HbV DNA, but now the surface antigen quantification has also been done, and now it is seen that the level of surface antigen concentration is directly proportional to CCC DNA, that is covalently closed circular DNA, which is the marker of actual activity of hepatitis B viral infection has been seen. The amount of HbS-AG is indirect marker of control of infection, and it acts as a surrogate marker to number of infected cells. So the titers of hepatitis B surface antigen are higher in patients who are in immune tolerant phase. I have already discussed when the person acquires this infection at the time of birth, then in immune clearance phase when the body has cleared the virus. So surface antigen can be measured by different techniques, and the clinical utility of these markers have been seen in, especially if we want to say, if there is risk of reactivation in E antigen negative chronic Hep B infection, surface antigen or DNA level more than 1000 and 2000 respectively, they shows this much level has got high risk of reactivation. Then prediction of HbS seroconversion, prediction of stage of fibrosis, prediction of development of HCC, and deciding how much should be the treatment duration in patients who are on oral nucleoside or nucleotides. Now we have oral drugs which are known as nucleotide analogs or nucleoside analogs. The duration of this can be decided by HbS quantification in patients with chronic Hep B infection. Coming to the second virus, hepatitis D virus. This is an incomplete virus. This requires presence of HBV infection. The clinical significance of this is there whenever a person gets hepatitis D along with B, that infection is more severe, and the diagnostic marker in this case is Hdb antibodies. This can be as co-infection. This can occur as a co-infection. That means both the infection, Hep B as well as Hep D, they have come at the same time in the person, or this can occur as a super infection. That means the person was having Hep B, chronic Hep B was there, and over and above HDV infection has come up, and suddenly the patient becomes severe, gets the severe infection. So this can occur as a co-infection or super infection. In both the cases, the severity of liver disease becomes much more when the person gets dual infection as compared to single infection. Coming next to hepatitis C. Hepatitis C is a virus which
Ma'am, your slide is not moving.
Hello?
Yes, your slide is not moving.
My slides are not moving.
No, ma'am. Nobody can see the slides. People are writing.
Okay. Now, can you see?
The same one is we can see. It's not visible, ma'am. Refresh it again, ma'am. Can you refresh? Yeah. It's a blue one.
Now it is seen. Yeah.
Genotypes. Yes.
So,
yeah.
May I know till what level people have seen? I will just say one word about each slide. This was seen or not?
This is the new one actually. Some more back, ma'am, please.
Okay. This was seen?
We were here only.
Achha, okay. So we were at the level that when the person has only total core antibodies. So what is the interpretation? The interpretation of only core antibodies is either the person is having false positive, that means he or she is susceptible to this infection, the past infection with low level chronic infection, or the passive maternal transmission. Sometimes these antibodies, they pass on from mother to child passively, so they can be detected. Now, this is moving or not? Vidhi?
It is not moving again.
Now?
Yes, ma'am. It is moving now.
This is moving, na? So next is only the person gets the anti-HbS positivity state. Rest of the markers are negative. So this shows either the person is having these antibodies secondary to immunization or secondary to sometimes immunoglobulin have been injected in a person. In those cases, this marker can remain positive for 3 to 6 months. Next, is it visible now?
Yeah, ma'am. Yes, ma'am.
Okay, the serology, the immune person. Sometimes we come across that the person can we differentiate a person who acquires natural these surface antibodies secondary to natural infection or vaccination. So this can be differentiated if the core antibodies are positive in addition to surface antibodies. That shows the person has acquired these antibodies following a natural infection. Whereas in vaccination, the only marker which will be positive will be anti-HbS. Is it moving now?
Yes, ma'am. Absolutely.
Okay. So isolated core antibody positivity state. This is seen in 10 to 20% of blood donors in high endemic area. What is the clinical significance of this antibody? Because this is a report which is sent to us by blood bank people, that the person who had come for blood donation and is found to be this core antibody positive. So should we take this blood or not? So this particular antibodies, either the person had past infection and is having low anti-HbS titers, or it is following acute Hvv infection, or he is or she is in window phase. So what is the clinical significance? That the person is not, the person cannot donate blood and cannot donate organ. So this person is rejected by blood bank people once this marker is positive. Next comes the hepatitis B DNA quantification. This is one of the most important marker which can tell us that whether the person is having replicative virus or non-replicative virus. So the clinical significance is when, now the slides are moving now.
Yes, ma'am. Yes, ma'am. It is moving.
So the clinical significance of HbV DNA, one is to know when to start the therapy in chronic Hep B. If this level is more than 2000 IU per ml, that means we need to start the therapy. The treatment monitoring also, when the drugs are given, how to monitor in addition to ALT or other markers. The most important marker is the HbV DNA. It should come down to negative when the person is responding. The treatment response, especially in pre-core mutant, as we don't have any marker. If E antigen is positive in a person and we start this therapy, then to assess the person has seroconverted, we have E antibody. But if a person is in pre-core mutant state, when E antigen cannot be secreted by him, so how to assess the response? In those cases, DNA will be the only marker which can be useful. Or patients who is having reactivation of non-replicative HbV infection and diagnosis of HbV infection in fulminant hepatic failure. Sometimes what happens, the person comes in FHF state and none of the marker is positive because all the hepatocytes, they have gone, and surface antigen secretion, we cannot pick up that. In those cases, the only way to diagnose that this FHF is because of HbV infection is by doing HbV DNA. Recently, a lot of work has been done on Hvv genotype. There are 11 known genotypes. In our country, we have A, C, and E. What is the clinical significance of that? It was seen prior to now new oral nucleoside analogs, which are nowadays used to treat these patients. We used to treat this patient with interferon, and it was seen the genotype A had a best response to interferon. So the response to therapy, spontaneous seroconversion rate, the pre-core or core mutation status, progression to cirrhosis, and the incidence of HCC, they all have been linked to HbV genotype. But presently, in the present time till today, all this is in research phase, and the clinical significance is not still there. A lot of work has been done on HbS-Ag quantification. Till few years back, we used to do only HbS-Ag positive or negative, but now we quantify this particular marker also, and it has been seen that the concentration of HbS-Ag is directly correlating with the level of cccDNA. Covalently, this cccDNA is the marker of number of infective cells in hepatocytes. So this cccDNA and the level of HbS-Ag concentration, they go hand in hand. So the amount of circulating HbS-Ag is indirect marker of control of infection and can be used as a surrogate marker to know the number of infected cells with HbV infection. HbS titers are higher in patients with immune tolerant phase, the phase in which the body and the virus, both they tolerate each other, and as compared to immune clearance phase, when the body tries to clear the virus. The different assays have been used to measure this HbA1C concentration. And what is the clinical utility? We can identify the risk of reactivation, especially in the patients who are E antigen negative. It is seen if the level of surface antigen is more than 1000 IU per ml and the DNA is more than 2000, there is high risk of reactivation. So these patients, they need to be treated. The presence of prediction of HbA1C seroconversion means how many of them will go on to develop surface antibodies following this infection is also can be predicted by HbA1C quantification. The prediction of stage of fibrosis, prediction of development of HCC, and to decide the duration of treatment in patients on oral nucleotides analogs. As when we start this therapy in cases of oral infection, oral antivirals, the endpoint is sometimes very difficult to make out. How long to treat these patients? Because there is no endpoint. In those cases, HbA1C quantification can come as a rescue. If the level of this surface antigen comes down, that means that level of cccDNA also comes down. So the therapy, we may stop the therapy once this level comes to negative. Next comes the Hdb virus. This is basically incomplete virus, requires presence of HbV infection along with that. My slides are moving now, Vidhi?
Yes, ma'am.
So the dual infection, what is the clinical significance? When the person gets both the viruses, the infection is more severe, and the marker which is there in HDV infection is anti-HDV IgM. This can occur as a co-infection, means both the virus HDV as well as HBV, they come simultaneously, or this can occur as a super infection. That means the person was having HBV infection and over that HDV has come up. So in both the cases, the dual infection appears to be more severe as compared to the single virus. Next comes the Hepatitis C virus. This is a virus which can cause chronic liver disease, and this was a very difficult virus to treat. Around you can say 8 or 9 years ago, this was the most difficult virus which caused chronic liver disease, and it was most difficult to treat. But now there is a paradigm shift in the management of this virus. Let's see the serological markers which can be seen in this virus when the person acquires this infection. The Hcv RNA, this is a RNA virus. It goes up and it comes down and it fluctuates because the chronicity rate in Hcv infection is around 85%. That means once a person gets this Hcv infection, around 15% of people only are going to clear this virus, whereas 85% will continue to have chronicity. And what will happen in chronicity? The RNA will continue and the ALT level also will fluctuate. The antibody to hepatitis C virus becomes positive in around 8 to 12 weeks after the infection is there, and it continues lifelong. So the presence of anti-HCV shows that the person has been infected with hepatitis C virus. But if we get this RNA along with that, if RNA is high, that means the virus is replicating. And if RNA is negative, that means the past infection is there and the person has cleared that virus. So the resolved virus, HCV. So what is the status in person who has come up and resolved HCV infection? The ALT and HCV. ALT will be high and then will come down to normal once the virus is cleared. The antibody will continue and the HCV RNA, which is positive in acute phase, will come down to negative state. So the resolved infection will have HCV antibodies only, normal ALT and HCV RNA, which will be negative. So how do we go about these patients? Once the anti-HCV is found to be positive, that shows that the virus, if this is positive, Then we get a HCV RNA done. If that is negative, that means either the person had passed or infection which is resolved, or sometimes these antibodies can be falsely positive in patients, especially in autoimmune disorders. These antibodies can be positive. So to confirm that the person is having this HCV infection, we need to get HCV RNA done. If that is detected, that shows that the person is harboring the infection. If that is not detected, that means the maybe it's a false positive or resolved infection. If anti-HCV is negative, that means the person has never been affected by Hep C virus, and if we strongly suspect that the person had been affected with C, we need to follow up these patients for further months. Hcv chronicity rate is around 75 to 85%, and we need to treat these patients. We have HCV antibody, RNA, which can be detected by PCR, and we had Hcv genotype testing till few years ago. We used to treat these patients. What is the importance of Hcv genotype? Because this virus is RNA virus, so high mutation rate is there. There are 6 genotypes, 1, 2, 3, 4, 5, 6, and they are subdivided also. What is the clinical significance? What was, in fact, because the type of therapy, the duration of therapy, and response to therapy, this all was decided by a genotype till few years back. But now we have pan-genotypic drugs. That means single drug is active against all the genotypes, and so the genotype may not be. Now we don't get genotype done in most of the cases, and it does not. The second important point is genotype does not influence the severity of liver disease or chronicity. It was only there to know the type of therapy, duration of therapy, and response, which was important parameter before the appearance of these pan-genotypic drugs. Coming to hepatitis A, which is a very common cause of sporadic or epidemics in developing countries, the marker which is there is IgM anti-HAV, which appears in acute phase, and IgG anti-HAV, which is there in chronic phase. So if a person is having acute hepatitis and this marker is positive, IgM anti-HAV, that means the acute infection is because of Hep A infection. And if IgG antibody is present and this is negative, that shows that the person had infection in the past and now is immune to this particular virus. The virus can be detected in stool for first 4 months, but this is only done in research labs. So the 2 important antibodies I have already discussed, IgM variety in acute illness and total or IgG variety, which shows either the person was affected by this particular virus, or sometimes the vaccine which is given for, we have a vaccine for hepatitis A, post vaccination also these total anti-HAV antibodies are positive. Lastly, coming to hepatitis E, this is another important cause of acute viral hepatitis in older age group. In children we have hepatitis A, and in older people we have hepatitis E, and the incubation period is 1 to 6 weeks. Again, this particular virus causes features of acute viral hep in which high enzymes are there, and the only marker in acute phase is anti-HEV, and the past infection can be seen by IgG anti-HEV. So just by looking at these 2 antibodies, this is again a protective antibodies. That means the person who has this IgG antibody to HEV, he is protective to another infection. So that's all. Thank you.
Thank you. Yeah, thank you, ma'am. Thank you. Thanks a lot for your very nice presentation. Ma'am, there are a few questions for you, which I'll read. Raghu Prakash Reddy is asking, does virus cross placenta barrier also?
Placental barrier is caused by hepatitis B infection, especially in cases when the virus is actively replicating. If the person is having Hep B infection and E antigen is positive, Hbv DNA is positive in mother, the 90% chance that this virus will cross the baby. The placental barrier, the baby will be positive to Hbv infection. In Hep C also, the placental passage is there, but not to that tune as in cases of Hep B. And in C also, it has been seen that if the viral load is very high in mother, in those cases, this virus can pass on to baby. For Hep B, we have drugs which are available. We give the medicines. If the viral load is very high in mother, we treat these mothers in last trimester with some drugs so that the viral load is reduced and the passage of virus to the newborn is reduced or minimized.
Okay, ma'am. Another question from Raghu Prakash Reddy. He is asking how many months core antibodies present in natural infection. Can we identify whether it's recent infection or past by?
Very, very good question. In case of acute Hep B, if core antibody is of IgM variety, that shows that this is an acute infection and this can persist for 6 months, 6 to 8 months. But after that, maximum 6 to 8 months, normally they come down around 4 months. But if after that we get these antibodies, that is IgG variety, that means the person had past infection. So total core antibody shows that the person can have acute as well as chronic. These total antibodies will be high. But in addition, if we have IgM core antibodies, that shows this is an acute infection which stays till 3 to 4 months. After that, only total core IgG is present.
Okay, ma'am. Another question is from our chat box. If anti-HCV is reactive low value by one method and non-reactive by another method, how do you proceed?
If anti-HCV is not there, say we get anti-HCV antibody positive, first reading, and the person is not convinced, then we get that antibody repeated in that person, because to say the person is harboring HCV infection is a very big thing. So we must reconfirm that. If that is still plus minus, we get the HCV RNA done. So that is the short method by PCR. If that is positive, then that means the person is harboring this infection, because these antibodies can be sometimes seen high in patients who have autoimmune disorders. So the false positivity is there in autoimmune disorders. So we try to clear that by getting a HCV RNA done.
Okay, ma'am. Another question by Raghu Prakash Reddy, sir. Does blood bank see core antibodies too?
Yes. I have told that this particular antibodies in high endemic area, around 10 to 20% people, they are found to have these antibodies positive. The clinical significance of these antibodies is we almost daily or alternate day get a referral from blood bank that this person is found to have this antibody positive. Can we take the blood? We have given instructions that once these antibodies are there, either the person had this particular infection in the past, or so indirectly we can say, because the DNA, the integrated part of HBV DNA can remain for life, and the blood cells or immune cells can also continue to have these markers. So these people, they cannot donate blood, and the organ donation also, they are not the candidate for that. So this is the clinical significance.
Okay, ma'am. I think you already answered this question during your presentation.
Yes.
Then another question came in case of needle stick, if HB comes positive, then how do treat?
That's a very, very pertinent question, because almost every week we get this query done from our say nursing staff or from hospital staff, because nowadays the people who join this medical industry, they are supposed to be vaccinated by 3 doses and to document that they have adequate antibodies to hepatitis B. This is a mandatory thing. But what people do, they write down that we got these vaccination and they don't produce that certificate and they get the dose. They get the job. Once they get a needle stick injury, they are panicked now because they don't know about their immunization status. So the first thing which is done, we get the anti-HbA status done in those people who get a needle stick injury. So if this level is more than 1000, the person already got the 3 doses of HBV vaccination, then and he is a responder to that vaccine. The level of HBV DNA, this anti-HbA status, if this is more than 1000, that shows that the person is fully vaccinated. There is no need of any immunoglobulin or nothing to be worried about. If the this level is between 10 to 100, then we give a booster dose. And if this level is less than 10, then what we do, we give a shot of HBV immunoglobulin, as well as we give a booster to that person at 2 different sites. So we protect this, because the protective role of HBV immunoglobulin is very much if a person gets a needle stick injury. And also at the same time, we get a HBV DNA done for the patient who was found to be HBV positive. So if the DNA was low, then there are low chances that this virus will be transmitted to the person who got a needle stick injury. So the immunization of status of person as well as the infectivity status of the patient who was found to be HBS positive, both are important to assess in such cases. And we can very well protect these people by immunoglobulin injection.
Thank you, ma'am. We have 2 more questions for you. One, both are in chat box. One question is, if HbS-Ag is positive and HBV DNA is negative, how do you proceed?
HbS-Ag is positive. I have given this in my presentation also.
Yeah, you have.
So there are 2 possibilities. One is the person may be acute phase of HBV infection. So what we can do, we can get a LFT done. If these serum transaminases are very high, that means the person is having acute HBV infection, and DNA in those cases, generally the DNA becomes positive within first 2 weeks. So if DNA is negative, only surface is positive, that means the person is in non-replicative carrier state, in which the body has cleared the DNA, but the surface antigen remains for the life. The clearance of surface antigen is not possible. Thus, there is only spontaneous clearance of surface, even if the person has cleared the virus in the way that the DNA has become negative, but the surface clearance is only the spontaneous. It is only 1 to 2% per year. So let's say, suppose 100 people, they get HBV infection, and out of them, say 90% have cleared the virus. The 10% who remains positive, out of them, the spontaneous clearance is only 1 to 2% per year. So now we are in development of new drugs which can clear this surface antigen, because the clearance of surface antigen as well as CCC DNA, if that comes, that will be a sort of, you can say, paradigm shift sort of in management of HBV, because till now we can suppress the virus. We cannot take it out. So by taking out surface antigen and CCC DNA, we can almost cure the person, or complete sterilization of person can be done.
The last question is, in HbS-Ag have some low value by one method, and second, simple non-reactive in other method. How to investigate further?
Again, we get a DNA done, just like in Hcv infection, if that is there, and we want to be 100% sure that this person has this particular virus or this is falsely positive. Generally, HbA1c is never falsely positive. This can be in low titers, but if that is there, to confirm this is replicative or non-replicative, we get a Hvv DNA done. So if that is positive, then we proceed in the way I have already told. If that is negative, then that means the person is harboring the infection, but is in non-replicative phase. We can follow, we can stage the patient according to different tests. I have already mentioned ultrasound, fibroscans, and we can proceed further.
Thank you, ma'am. Thanks a lot for very nice presentation. And for this, we would like to give you an appreciation certificate. Later on, we will give you its hard copy also as possible. So it's your appreciation certificate. Please accept it, ma'am.
Thank you. Thank you. Thank you.
Thank you. Thanks a lot, ma'am. And actually, we learn a lot from you all doctors, and need to go away, miles to go actually in this medical industry. And today's fourth and last session, no, it's not least session, it's the last session of CME. We will have Dr. Rajesh Gupta, sir, and he will be sharing the updates on celiac diseases. I would like to give some introduction of Dr. Rajesh. Dr. Rajesh Gupta is a senior consultant and it's gastroenterology and hepatology at Asian Institute of Gastroenterology, Hyderabad. He has 21-year experience in medical gastroenterology and hepatology. He is proficient in all advanced G1, G.1 endoscopy procedure. Special interest in endosonography and capsule endoscopy. He has plenty of experience in medical research and a number of publications to his credit. So, Dr. Rajesh Gupta, stage is yours. Over to you, the mic and the center of screen. Please, sir.
Thank you, Vidhi, for the kind introduction. At the outset, I would like to thank Dr. Neeraj for giving me this opportunity to participate in the CME program. So, why celiac disease? Because this disease interests all the specialties. It's a myriad of presentations. And what I'm going to do is the next half an hour or so is to share the clinician's perspective, not as a gastroenterologist alone, but primarily my focus will be on as a gastroenterologist, how I approach this disease, which afflicts children as well as adults. And the patient can land up in any specialty, which you will come to know later on. So it's not moving. The slides are not moving.
No, sir, it is not.
Yeah,
moving.
no, it's not started.
Okay. Moving. Yes, sir.
So as you know, why the celiac? Celiac disease is a very interesting disease. It's a chronic disease which afflicts the small bowel, primarily small intestine, and it's an immune mediated. We call it immune mediated enteropathy, which occurs as a result of exposure to dietary factors. The dietary factors are basically gluten. The gluten containing wheat, rye, or barley, and these patients are generally genetically predisposed individuals. And why? Because this injury, it leads to a chronic injury to the small bowel, which in turn results in villous atrophy as pathology, as a histopathology. And as a result, it causes malabsorption of variety of nutrients. And interestingly, if we stop the gluten exposure to the small bowel, it is reversible. That's the beauty of this disease. And if the person is exposed to the gluten again, it will relapse. So interesting thing is, this disease, if it is diagnosed timely, it can be managed properly, it can be easily reversed. But the problem is, what we see in our clinical practice is, we see a small percentage of patients who have classic features, that is diarrhea, weight loss, nutritional deficiency. That's a small subset, what we call the tip of the iceberg. But a large percentage of patients, especially adults, they come with atypical features. So we call it atypical celiac disease, but they can present with either anemia, abdominal discomfort, or number of features which I'll discuss in subsequent slides. So these patients are called atypical, but if they are investigated, you will come to know that these patients have celiac disease, and primarily they present in adult life, and they are these days, they are called non-classical cases. But some patients, they don't present with symptoms. They are sitting silently. They are called subclinical cases. If you investigate these patients, why we investigate? Because they are close family contact of the patients who are harboring celiac disease. So if we investigate these patients, they will be celiac antibodies will be positive, seropositive, and the biopsy will also go. The last group would be latent group, what we call. They are likely to develop celiac disease if they are exposed, but they have potential to develop celiac disease. Sometimes they remain silent, their serology may be positive, but they can, if they are challenged, they can develop in their lifetime celiac disease. And these are the patients which have potential to develop celiac, classical celiac disease. But there are a small group of patients, less than 10% approximately, those who are not classical celiac, but they are they have celiac gluten sensitivity. So how do we diagnose? They will be positive for serological antibodies will be positive, but they are not true celiacs. So the other important thing is to remember is the celiac disease, is primarily the mainstay of therapy in celiac disease is gluten-free diet. If these patients are kept on gluten-free diet and they strictly adhere to the gluten-free diet, they will respond. The clinical response will happen within a week. The serological response and histopathological response takes a little longer. And then comes the chronic deficiencies. They will also be corrected over a period of time. But in spite of strict gluten-free diet, if these patients, they do not respond, we call them refractory celiac disease, and then we evaluate further, and I will get to back to this area subsequently. So history is always very interesting, and the history of celiac disease is also equally interesting. It is not because only the interest. We should know history because how much effort our predecessors have done to study this disease, and how this current knowledge, what we have achieved today, what is the contribution of our predecessors. So that is just a brief summary of this history of the celiac disease. It is known since 1st century by Atricius. Then there was a long silence. Then till the 18th century. In 18th century, because in Dutch group, they reported that there are a lot of oral ulcerations in these patients, and they were called sprue in Dutch language. That's why it was called sprue. But the first scientific basis or scientific study was carried by Samuel Guy. He was also a Dutch national and as a scientist, and it's first time he gave the role of dietary factor in this disease, and that too in 1888. And it shows how scientific acumen of the gentleman. He said diet is primarily responsible for development of this disease. Then came the era where the real scientific discovery about the real scientific analysis was done, scientific studies, and this is Professor William Dick, and this was a first time this gentleman, he was a pediatric clinician, and he observed that during World War II, when there were due to the war, there was short supply of wheat bread, there was significant improvement of children who were suffering from diarrhea. And in fact, this observation was made to one of the mother of his patient. And then he started paying attention in his pediatric ward. What he saw was there is a significant decline in fertility. The children started improving the moment they were having not access to the wheat bread. And that's how he started analyzing scientifically. And he came out with this hypothesis that primarily it is the wheat which is the toxin and it causes this disease. So this is way back in 1944. And subsequently, there is a very rapid journey, not so rapid as compared to what we see in our now current knowledge. So then we came to know the wheat insoluble, Van de Kamer isolated this water insoluble gluten, which are responsible for this disease. Then the histopathology of this celiac disease was discovered by Pauly in 1956. Then subsequently in 80s that we came to know that there is a role of HLA DQ2 and DQ8 in the predisposition to the disease. And then subsequently these tissue transglutaminase were isolated and they were discovered and then their role was defined. And subsequently this further progression has been made. And now we have electron microscopic evidences. Now we can say that there is now evidence that there is an injury at the cellular level, and now we have better understanding of the pathogenesis, which lead to us to believe that which are different targets and which can the pharmacotherapy can be developed. Other than this gluten-free diet, I would like to emphasize gluten-free diet is the mainstay of therapy, is still on the day, but now there are a lot of therapies, future therapies are being developed based on the pathogenesis. India is also not far behind, but we started a bit late. The first report started appearing in 1965. Then there was a lot of reports started being reported from India from up to 90s. Then scientific systemic studies were started a bit late in our country. And then from northern India, there were a lot of reports that this disease is not so uncommon. So then what happens now, from North India, Western India also, several reports and several centers started reporting that this disease is not uncommon, primarily because the wheat eating area is north and west is the primary and central India. That's the reason more of the cases started being reported from this area. Southern part is primarily rice eating belt. So that's the reason the cases are less reported from southern part. So if you look at the epidemiology, if you see the concentration of the cases, the majority of the cases come from the wheat consumption area, but it is not that it cannot happen in other parts of the world. So it's primarily afflicts the children, as I said earlier, and the more the children are exposed to the gluten-free, the gluten in the cereals at a young age, approximately by age of 3 years, they approximately 1/3 patient, they develop villus changes, villus atrophy, and they will show serology positive. So this is what one need to remember. And the second important thing is, what are the histological changes? Now coming to that. This is a very important, for pathologist's point of view, what we call the Mars classification. As we, subsequent slide, I will show what is the role of these IELs, that is intraepithelial lymphocytes, because they are the primary event, the primary cells which initiate the injury to the intestinal epithelium. And it's a disease of epithelium, migrated, and the rest of the mucosa, they get slowly, completely the mucosa gets atrophy. So the first event, if you look at the pathology, histopathologically, what you find that normal mucosa will be, that's a healthy epithelium. Healthy means the villi is, and the crypt villi crypt ratio is 3 or 4:1 in the normal healthy adults. But in the second stage, once the initial injury starts, there will be increase in intraepithelial lymphocytes. That is called SMART stage 1. Then the crypt hyperplasia will happen. That is called stage 2 disease, SMART stage 2. If there is a complete disarray or partial atrophy, that is called stage E, and there is complete atrophy of the villi, that is called stage 4 disease. But mind it, simply based if the intraepithelial lymphocytes are there, they may not be, they may be seen in other infections also, like HP infection, duodenitis, and that could be a non-specific finding. So mind it, you have to take this histopathological finding in conjunction with serological markers. And now we know that there is a role of tight junctions, what we call the leaky gut concept. If there is injury to this tight junction by the zonulin agonists, these can lead to further aggravate the injury, and slowly the whole of the intestinal epithelium gets denuded. And now we have ultrastructural changes also we can understand, and now you can do, if you see the electron microscopy, you can see these changes. So now coming to the pathogenesis, how this disease is initiated. As I said earlier, it is basically an interaction of dietary factors in a genetically predisposed individual, and which initiates the injury, that immune-mediated injury to the epithelium, intestinal epithelium. So how it happens? Because these wheat and barley and the rye, they come from a grass family. As you can see this chart, which shows that. And they have very high concentration of glutens. So the wheat contains primarily the gliadins and glutens, barley contains hordeins, and rye contains sicalins. And all these three, they initiate what we call the initial trigger in genetically predisposed individual. And once they are absorbed by the intestinal epithelium, they trigger a sequence of events, cascade of events, which leads to intestinal epithelial injury. So this is how, once somebody ingests in normal individual diet, adult diet, it contains 25 to 30 grams of gluten. You can imagine. And this gluten is not digested by any of the gastric, pancreatic, or intestinal enzymes, because these are water insoluble. So what happens, if this much load is presented to the small intestinal epithelium, it gets passed through the intercellular, paracellular pathway and enters the lamina propria. In a genetically predisposed individual, those who have HLA-DQ2 receptor T cells, so it presents this antigen presenting cell in HLA-DQ2 or DQ2-8 positive persons. These antigen presenting cells present themselves to this gluten, this gliadin, which are these are the toxic proteins which are ingested, and they attach to themselves. And once they attach themselves to these antigen presenting cells, they activate T cells. So once these T cells are activated, so it leads to a series of other steps. And simultaneously, in the lamina propria, these proteins, these gliadins, they are broken down by tissue transglutaminase, and which breaks down this bond with proline and glutamine. And once this bond is broken, it releases negatively charged these glutamic acids. So what they do is they have a preferential attachment to these T cells. And these basically these T cells, which are primed with this genetically predisposed HLA-DQ2 and DQ8 T cells, and which are special affinity for these kind of cells. And once these attach into the grooves of these T cells, so they further initiate the inflammatory cycles in the cells, intraepithelial cells or enterocytes. So which in turn damages the cell further, and slowly, once this is initiated, it leads to further injury to the cells, and this whole of the intestinal epithelium becomes villous. It gets completely destroyed. And this injury goes on and on until unless we interrupt this injury agents. So this is how it happens. And initially what happens is, if the children who are exposed to these cereals, they will start the moment if they are exposed to these cereals in first 3 months of their life, at 3 months of age, they are more likely to develop initial injury, and they are likely to present in first 3 years of their life, and they will have even in the first year of their life, and they will have significant symptoms. And now coming to the clinical symptoms, as a clinician, this is of most interest to us. So primarily, we used to believe that is a disease of children. So the children, the most common symptom would be failure to thrive. They will be apathetic, they will be irritable, there will be muscle wasting, they will have hypotonia, and obviously abdominal distension and diarrhea. And over a period of time, they will tend to develop anemia, they will have osteopenias, and these are the different presentation in children. But sometimes they can have other associated diseases also, and because if there is a significant villous atrophy, which can lead to severe abdominal pain because of intussusception, and very rarely, though it doesn't happen, it can develop intestinal lymphoma, but which is a late presentation, but doesn't present so early. So coming to the adult presentations, as I said, because why it is of interest to all the physicians, because different specialties, it can go to any specialties, as you can see in this chart. It can go to a dermatologist, it can go to a neurologist, it can go to endocrinologist, hematologist, and neurologist. So it can go to any specialty. So that's the reason, if these patients, as an adult, they come to any specialty, we should keep this possibility in mind. So if somebody who is having severe anemia, hemorrhage, bleeding, excessive bleeding, so these patients will be investigated on different line. But one must always keep this possibility of underlying celiac disease in mind, especially in adult patients. These patients can have cutaneous manifestation like chymosis, petechiae, dermatitis herpetiformis is very, very important. It's a classical finding which we see in some of these patients. As a liver specialist, they can come to elevated liver enzymes, and this is not uncommon finding in celiac disease. They can present to endocrinologists like as infertility. They can present with the secondary hyperparathyroidism. They can present with orthopedic surgeon, orthopedic department with pathological fracture due to osteopenias. They can present to neurologists with peripheral neuropathies, ataxias. And interestingly, this is a occipital calcification, as you see in this CT. And this is a syndrome, what we call CEC syndrome, where celiac, epilepsy, and calcification. These are some case reports which you will find in literature. The point is, what I'm going to, it can present to any specialties if you carefully evaluate these patients. Now coming to the another important aspect for the diagnosis, that is serology. As I said, other than the clinical manifestations, the serology, we order first relevant serology. Serology is very, very important for making a diagnosis of celiac disease. So what are the serological markers? So we have two primarily serological tests. One is EMA, anti-endomycin antibodies, and the second is TTG. So these are the two, and because these serological tests, these are very sensitive, very specific, and very high positive and predictive value and negative predictive value. So these tests are very, very sensitive tests. Antigliadin antibodies, first generation tests were moderately sensitive. That's why they are not recommended. But now your second generation tests are also available, so which are more sensitive. So there are maybe some cases where you may have these TTG, because earlier they used to use guinea pig gut, which was used to report give sometimes false positive result. But with the human umbilical cord now is being used for this as a base for this testing the TTG, so which is very, very specific. So the decrease in there is a false positive test have come down significantly. There are certain situations where the results may be falsely negative, especially in young children, those who have IgA deficiency. So if you clinically suspect that there is a possibility of celiac disease, but the tests are negative, then just do check your IgA deficiency, because this is one condition where the test may be falsely negative. The other thing is, if you still feel that the serological tests are negative, clinical suspicion is there, then you do second injection DGP test, deaminated glycated peptides, because these tests are very, very, that will turn to be positive, and these tests are used in that situation. We ask for these tests. So this is the chart how we approach these patients. So first, if we classify these patients, whether there is a clinical high probability or low probability. If there is a low probability, we order obviously for the serological test. If the serology is positive, we do duodenal biopsy. Now we have different ways we can easily do, and this endoscopy is easily available everywhere, and this simple test, you can do biopsy. If the serology is negative and there is biopsy is not required in that stage, then we exclude this type. In a very rare situation where the strong clinical suspicion, then we sometimes proceed with biopsies. Otherwise, we generally stop there. But if there is a high probability, then we do both serological tests and biopsies. And if there's a biopsy is positive, serology is positive, it confirm, we put these patients on strict gluten-free diet. If there is a biopsy is plus questionable, antibody is positive, then we repeat the biopsy. And if it is positive, then we consider. But if the biopsy is still negative, then it could, when the serology is positive, there are two possibilities. One is it could be potential, which may manifest later on, or it could be false positive. But if the serology is negative, but histology is plus minus, it means it shows, because histology is not classical until unless, because it can the same villus atrophy, increase intraepithelial lymphocytes, they can be seen in other conditions. So you have to exclude all these causes which are listed here. I'm not going to discuss all this condition in detail. So then you have to think about this. This could be non-celiac in that case. Okay. So when we do endoscopy is another our armamentarium in our as a gastroenterologist, which we use. The endoscopy could be classical, the standard EGD, or it could be capsule endoscopy, video capsule endoscopy. So if you are using, ideally we should use, if the access is there, do endoscopic biopsies, that is from the just below the ampullary area, or you can take it from D2, because there could, if you do from D1, there could be false interpretation, there can be sometime it can be missed also. So what we see is we see if the villi is normal, it means that is less likely, or there is a very, very unlikely that it's a celiac, because in the celiac, what we see the scalloping of the mucosal fold, we can see the fish ring, but we can see the scalloping, and then we can see the mosaic pattern or flattening or absolute flat mucosa. This can also be seen in capsule endoscopy, but the problem with capsule endoscopy is we cannot take biopsies. So that's the reason I say, if possible, always do biopsies with the upper EGD. Sometimes with the capsule endoscopy, if we do capsule endoscopy, the advantage is we can see the deeper part of the small bowel, where we can see the ulceration in the jejunum. We can see strictures also sometimes, which may be missed by upper GI endoscopy. This capsule endoscopy is important in certain situations that I will come to know come a little later. So this is the slide where we do. So in diagnostic part, we generally don't ask for video capsule endoscopy. The reasons are two. One, it is expensive. Secondly, we cannot take the biopsies. But if the patient has improved on gluten-free diet, there is diagnosis is already established, then there is no need to further follow. But the problem starts if the patient is strict on gluten-free diet, for more than 6 months, and if child is not, or the patient is not improving, in that case, we should order this. The reason being, it could be refractory celiac disease, and we can miss certain things, ulceration and stricture, which may be there, which can be easily missed on upper GI endoscopy. In that situation, if the patient has obstructive symptoms, there is a caveat here. If there are clear-cut obstructive symptoms, don't ask for video capsule endoscopy, otherwise it will get stuck. But if there are no clinical obstructive symptoms, then you can order video capsule endoscopy. If the patient has obstructive symptom, then the role of imaging comes. Earlier, we used to do a lot of imaging by barium. Barium is outdated these days. Very rarely it is practiced. There are several, these days we use either CT enterography or MR enterography. So the basic rationale is, so the bowel loops, once they're advanced celiac disease, the bowel loops will get dilated, they will be fluid filled, and there will be, similarly, there will be excess of fluid in the bowel. So what it will lead? It will cause dilatation of the loop. If you do barium studies, you will see flocculation, you said molas formation, reversal of fold, and the laminar flow will be seen in the imaging. These similar findings can be seen in CT also, or MR enterography also. So, but the advantage of CT is you can see the lymph node, which you cannot see in barium studies very clearly, but some expert barium radiologists, our seniors, some who has more experience with barium studies, they can pick up these small changes also. But the modern radiologists who are not seeing so much of barium studies, they can still miss. So they are more used to CT. So these days we ask for CT scan and MR enterography. There are several signs which can be seen. There can be telescoping, which can explain the pain abdomen intussusceptions and what you can call that the fluid. You can see in these CT images, there is a lot of signs which we can see. These are different signs which you can see here in the CT images. There will be increased color. The colon is also equally distended. There could be incrustation of the colonic wall. All these features which will be seen. And the beauty of this disease is once you start gluten-free diet, if the patient starts clinically improve, then slowly these images will also start improving. As you can see here, so there is, once the patient starts showing improvement, there will be resolution of the signs which we are seeing on CT imaging. So that is another important role of imaging in these patients. As I said earlier, abnormal liver function test can be seen in celiac disease, and in one of the studies which was published earlier, around 40% of patients had abnormal liver tests with celiac disease. And the advantage, so if you start these patients on gluten-free diet, these tests are becoming normal. But if these tests persistently remain abnormal in spite being on gluten-free diet, then we have to investigate for alternative causes of abnormal liver test. There are certain, as I said, this disease doesn't come alone. Sometimes it can be associated with several other diseases, and there are some documented definite association with celiac disease. So as I listed in this table, like dermatitis herpetiformis, type 1 diabetes mellitus, epilepsy, hypothyroidism, hyperthyroidism, pulmonary hemosiderosis, IgA deficiency, microscopic colitis. But type 2 diabetes has no association with celiac. So, and there are some possible association also that we should keep in mind, because if these patients come with these kind of diseases like Addison, autoimmune hepatic anemia, cavitary lung disease, so idiopathic thrombocytic purpura, you should keep in mind, back of your mind, that there could be possibility of underlying celiac disease that it could be associated with that, and we should investigate. Okay, so now coming to the most important thing as the management is concerned, as I said, the gluten-free diet remains the mainstay of therapy for management of these patients. So the cereals should be avoided. And what are the cereals? This wheat, barley, and rye. But the patient can be easily take because the rice, maize, oats, millets, these can be taken by the patient. This has to be substituted because wheat, barley, and rye, they contain toxic gluten. So these are to be excluded from diet. And this is not one time, it's a lifetime. And these are the substitute which are given here. The other important thing is variety of things directly, inadvertently, sometimes these patients, they take other things, especially adults, they take beer or sometimes they take chocolates and sometimes these tablets which can contain the coating of, because viscoelastic properties of gliadin, the gluten is used to make these substances. So you make sure that these patients are fully aware which substances they are consuming, they don't contain any gluten, because that is one of the most important cause of non-response to the gluten, non-resolution of celiac disease. So we organized this Celiac Disease Task Force in 2009 at AIG, Asian Institute of Gastroenterology, Hyderabad, and we came out with certain recommendations that time, say how to manage this celiac disease. So the most important, as I said, is adherence to the strict gluten-free diet, which is easier said than done. So they should have a regular consultation with the skilled dietitian, because nutritionists, because they are the people who are going to tell them what substances, what dietary product they can use or what dietary product they should avoid. And they should always join self-help group or the support group. That support group are very important because it motivates them and it gives them ideas what are the new substances, or where is the gluten-free diet is available, or how to prepare, because these are lifelong problems. So some patients, they can't afford these commercially available gluten-free diet, though they are rarely available in metropolitan cities. These are available these days. Earlier, they were not available. So how to prepare this cheap alternative at home so that they can save a lot of money. The other important observation what we have seen is that children are very compliant, but whereas the adults, they digress. So it is very, very important to reinforce the dietary advice in these patients, and the role of the support group is very, very important. It should always be re-emphasized. Now, once we have started this gluten-free diet and the patient has responded to treatment, it solves the problem. But there will be a group of patients who, in spite of being on gluten-free diet, strict gluten-free diet, they continue to be symptomatic and they fail to respond. So we call it non-responsive celiac disease. So non-responsive celiac disease means they, in spite of being on gluten-free diet, they are not responding. Then in that situation, we have to do two things. One is we have to revisit the diet, because that is the most common cause of non-response. If we have carefully revisited the diet and we have found out there is no digression, no ingestion of any gluten-containing substance, in spite of that, the patient is not responsive, then we should declare it as a non-responsive or refractory celiac disease if 6 months have passed. If there is a possibility that we have, which is very extremely rare, it may not be celiac, but which is very, very less likely. So this data, this is an interesting data which was published by Dr. Puri, A.S. Puri from New Delhi, and he's shown that he studied 99 cases of celiac disease. So he found out, selected 99 cases of non-responsive celiac disease. What he found that there was inadvertent contamination of gluten in more than 1/3 of patients. So that is the importance of revisiting the diet. Another 20% patients, they have IBS, and only 10% of the patients were refractory celiac disease. So the problem is, the most important thing is we have to revisit the diet. We have to emphasize the dietary adherence to the strict gluten-free diet to understand. Very small percent of the patient, that is 10% of patients with celiac disease, will be refractory celiac disease. Now coming to the refractory celiac disease, a little small this thing. So it means if the patient who is known case of celiac disease, it continues to be symptomatic in spite of being on strict gluten-free diet, then it is considered as refractory celiac disease. There could be some situation where there be mimickers or which mimics like celiac disease, but that percentage is very small. So if we have established that there is a refractory celiac disease, then we have to do biopsies and we have to do cytological cytoflowmetry to differentiate the type of cells, whether the T cells are normal, abnormal, because that will decide the future course of treatment. So let me just quickly show this. So what is, if you do cytoflowmetry in these patients, if you have find that biopsy is a suggestive celiac disease, there is a severe villus atrophy, and then you submit these epithelial cell for cytoflowmetry, and you find that there is a normal, no abnormal intraepithelial lymphocyte. It is RCD1. RCD1 means the patient has celiac disease, not responded to gluten-free diet, and there is severe villus atrophy, but without any abnormal IL. That is RCD1. But if there are abnormal ILs, that classified as RCD2 because there will be a difference in the management. So how to approach the review diagnosis? The first thing, if you suspect any RCD, refractory celiac disease, first you revisit your diagnosis, review the dietary review, make a comprehensive dietary review. If any other additional cause is there, exclude that. Then you do cytoflowmetry. If any abnormal T cells, then you evaluate further. And if you are finding abnormal T cell, then exclude malignancy, that is T cell lymphoma. So if you find RCD1, treatment would be obviously immunosuppressive therapy and very rarely infliximab because it's also been used. These are treatment options. But if you have found that this is not type 1, then you have to seriously, if the patient is deteriorating, if there is a strong clinical suspicion of lymphoma, but it is not very easy to pick up. But unfortunately, if you get delayed in diagnosing ET cell lymphoma, the prognosis is extremely poor. Even the 1-year survival of this EATL is in this enteropathy associated T cell lymphoma, 5-year survival is very, very dismal. It is 11%. So once you suspect, you have to carefully select the biopsy, submit these patients for proper flow cytometry, do proper imaging, and look for additional imaging, especially those who have concomitant malignancy like CA or pharynx, esophagus, and small intestine. Always consider this possibility. The important thing to remember is, again, the role of gluten-free diet. If a patient is in strict gluten-free diet, it also reduces the risk of malignancy. It is uncontrolled disease, or if the patient is not adhering to the gluten-free diet, their risk of malignancy also increases progressively. Now coming to the last part of my talk, as I said, the mainstay of therapy continues to be gluten-free diet. But now people are started looking beyond the gluten-free diet because it is easier said than done. It is not easy for a normal person not to eat. There is a lot of social restrictions. He cannot eat or she cannot eat any food outside, enjoy the food outside. So the people have started looking beyond that. So there are several approaches. One is, can we make this gluten containing wheat, varieties of wheat, barley, less toxic, or which the patient or celiac disease can tolerate? So there have been attempts. Earlier, there will be what we call the ancient wheats. They have been tried and they have been treated, but there is still a work is going on. The other approach is, because this gluten, which is not digestible because it's not water soluble. So the enzymes endopeptidases, which are present in an intestinal epithelium, they cannot break down this gluten in the intestine. So can we make it pre-digested? So when you make a dough of the wheat flour, you add some digestive enzymes. So that is another approach, and so you break down. That is something called sourdough kind of thing. Third approach is, once these because the second, in pathogenesis, as you would recall, this is the role of transglutaminase inhibitors. So if you transglutaminase, they break down this bond and which lead to cellular injury or T cell activation, which leads to injury. So what you can do is if you inhibit this transglutaminase, the further injury can be halted at that stage itself. In spite that gluten has entered, or this gliadine has entered into the lamina propria of the cell. So that is another approach. The next approach is once the cytokines are released, you can use this anti-inflammatory cytokine drugs which are currently available, but that strategy is still in the nascent stage and the various phase 1 and phase 2 studies are going on. So this is a recent study which was published in New England Journal, which has used a randomized trial of transglutaminase inhibitors. So in this particular studies, they have used 3 different doses, 10 milligram, 50 milligram, and 100 milligram, and compared with placebo. And what they found was that it increases the vellus height, one, and secondly, decreases and it's specifically in the dose of 50 to 100 milligram, and it appears to be promising drug. But it is very early days. This drug is very expensive, and we have to see how long this drug can be used, because this is a lifelong disease. So various therapies are going to come in future. The future seems to be fascinating. The only thing is, at the moment, I would say this is an interesting disease, which is of interest to all the specialists and easily diagnosed if you keep this possibility in mind, and if it is diagnosed timely, and then it can be managed very well in very early without any additional cost. Thank you very much for your patient hearing. I'll stop here and I'm ready to take some questions.
Thank you, sir. Thanks a lot. Sir, Raghu Prakash Reddy have sent 3 questions for you.
Okay, sure.
Information. Thank you. Are there any associated specific psychiatric disorder in celiac disease?
Yeah, there are some, because if you recall, I go back again. So psychiatric as such, direct association, this is a possible association with schizophrenia. You can see in the list of this if you carefully list. But there is no direct association, but there is a possible association is there with the schizophrenia. If you carefully look at this. But there is definite association with this list. It's not there.
Okay, sir. So the next question to you is, any stool test to get gluten intolerance test, like occult blood?
No, occult blood is basically, it would be sometime positive once the intestinal epithelial injury, but it has no specificity or no role in diagnosis as such. So the only thing is we do stool tests to assess the fat loss, what we call Winding-Kammer method, which we generally these days are not using. For the diagnostic point of view, what we do is we check only the serological marker and intestinal biopsies, that is duodenal biopsy by ICMR protocol. As I said, you take 6 to 8 biopsies just below the ampullary area.
Okay, sir. The third question is this disease is reversible at any stage, or diseases if gluten-free diet? If we take gluten-free diet?
No, the gluten-free diet is a lifelong thing. If there is a definite diagnosis of celiac disease, it's a lifelong adherence to the gluten-free diet must be observed. At the moment, there is a lot of work, as I said, is going on. In future, maybe we will be able to give some gluten, whether by partial digestion through the wheat flour, which you can pre-digest and break down these glutens in the door stage itself, or we can have certain varieties of the wheat or genetically modified wheat, which will be containing less toxin. So in that point, but at the moment, there is no alternative. But maybe in future we will have.
Sir, another question is there. Can we get normal TTG in celiac disease?
Normal?
Get normal TTG in celiac disease.
Yes, if the patient is on strict gluten-free diet, these TTG markers, they will turn negative. These antibodies will disappear.
Okay, sir. Thank you. Thanks a lot for this session. And
Thank you, Vidhi.
so we would like to present here one appreciation certificate for you. And it's hard copy. We will send you soon.
Thank you.
But I'd like to share that certificate with you on the screen. So this is for you.
Thank you. Thank you, Vidhi. Thank you, Dr. Neeraj, for giving this opportunity. I enjoyed this session thoroughly.
Yes.
Thanks a lot, Dr. Rajesh Gupta, for your presence and sharing your vast knowledge with all our participants. Thank you very much for your support. And thanks to all the speakers, Dr. Barnali Das, Dr. Hcv Gupta, Dr. Monica Jain, and Dr. Rajesh Gupta for sparing time for our conference. So now, Vidhi, I think we can conclude the meeting now.
Yes, sir. Sir, actually, it was very invigorating session today in the CME. We learn a lot, and we need to close this. Before we close it, I'd like to thank J. Mitra and Company, Milap Medical Education and Learning Point, and special thanks to Delhi Medical Council for those credit points also, which they are giving the doctors. And seriously, it was immense learning to all of us. We at TIDE-CME right now, and hope that everybody enjoyed the session, these 3 days session, and we look forward to reconnect with you all again soon in future with few more exciting information of with CME. Until then, very much thank you all the doctors who have been here. Thank you, Dr. Neeraj Jain, for your support. And thanks, everybody. Namaskar.
Namaskar. Thank you.
Thank you, sir.